person.
And they're getting to change the clock, so.
And go, you can grab that there. We got to, really. Moving.
Have to put in several forms to get that done.
Yeah.
Yeah.
All right, good morning. I'd like to call to order the State Employee Benefits Committee meeting for Monday, March 9th. We do have a packed agenda. We're scheduled to go from 9 to 12. And so I would like to have Danielle with the Statewide Benefits Office do a roll call to mark the presence of SCBC members.
Director Maxwell,
Present.
Secretary Gordon,
Present.
Lieutenant Governor Gay. Not present. Treasurer Davis,
Present.
Commissioner Navarro,
Here.
Secretary Young. Here. Deputy State Court Administrator Ashley Tucker. Deputy State Court Administrator Ashley Tucker.
We have difficulty with her microphone. She is present.
She is present. Jeff Tajner,
Here.
Paul Baumbach,
Present.
Karen Peterson,
Here.
Bill Oberly.
Here.
Controller General Ruth Ann Miller.
Here.
Moving right along, we have agenda item number 2, which is the approval of the April 13th, 2026 SCBC meeting minutes. But these ones had corrections on them now. Okay. That was on the agenda.
Yeah.
Anybody have a motion to approve the minutes?
So moved.
I have my hand raised, Mr. Chair.
All right, I'm sorry. Oh, we
No
have a motion. Do you have a comment? Can we get the motion first and then you have a comment, or what do you?
Well, I have something, we can do an adjustment after the motion's entered if you'd like, that's fine.
We can have discussion on the motion. All right, okay, Paul. Comment.
Yes, I'd like, let's see, page 6 under public comment to be noted that, we had 15 written public comments, all of which requested no changes to GLP-1 coverage. I think that addition would, help the minutes fully reflect the nature of the public comments for that meeting.
So I will entertain a motion to approve the February 13th meeting minutes with the caveat that additional description as to the nature of the public comment that Paul just mentioned.
So moved.
Second.
Motion been moved and seconded. Any further discussion?
Can we confirm? Oh, sorry.
Adam on.
As long as we confirm that it's exactly 15, and since we're gonna put a number in there, I want to be very clear that all of the public comment was consistent with the motion.
I don't think anybody has any objection to that, do we? Okay,
It's fine.
all right, roll call.
Director Maxwell,
Yes.
Secretary Gordon,
Yes.
Treasurer Davis,
Yes.
Commissioner Navarro,
Yes.
Secretary Young,
Yes.
Deputy State Court Administrator Ashley Tucker. She is having mic problems because I did just receive an email.
She's
Oh,
here.
thumbs up, okay. Jeff Tajner,
Yes.
Paul Baumbach,
Yes.
Karen Peterson,
Yes.
Bill Oberly.
Yes.
This is Kyle Evans Gay. I'm voting yes.
Yes.
All right, moving on to agenda item number 3, we have the director's report. I'll turn it over to Director Hardos.
We have the approval of the executive session minutes as well.
It wasn't on there. I'm sorry, we have a 2A, so I would entertain a motion to approve the executive session minutes.
So moved.
As
Second,
motion and a second, any discussion? Seeing none, roll call?
Director Maxwell,
Yes.
Secretary Gordon,
Yes.
Lieutenant Governor Gay,
yes.
Treasurer Davis,
Yes.
Commissioner Navarro,
Yes.
Secretary Young,
Yes.
Deputy State Court Administrator Ashley Tucker, Jeff Pasmer,
Yes.
Paul Bumbach,
Yes.
Karen Peterson,
Yes.
Bill Oberly.
Yes.
Okay, now moving on to agenda item number 4, which is statewide benefits office director's report. I'll turn it over to Director Hartis.
Thank you, Director Maxwell. Good morning, everyone. Starting with benefit updates. So the SBO is currently working with all of our vendors to execute any contracts and amendments for fiscal year 27. And I wanted to provide an update on our contracts with our 2 dental vendors, Delta Dental and Dominion National. The state is entering into year 5 of our agreement with both of those vendors, while a procurement will be taking place this summer for a new contract effective FY28. As part of the RFP award recommendation that was approved by the SEBC back in 2022, both Delta Dental and Dominion have the ability to implement a premium increase of up to 3% for year 5 of the contract. The SBO had requested that both vendors maintain the current rates and to not implement that 3% increase. However, based on incurred claims analysis conducted by both vendors, they have both opted to implement the available premium increase effective July 1st. So what that equates to for Delta Dental, that will be an increase for employee-only coverage of $1.16 per month, up to $3.86 for family. And for the Dominion National, the DHMO plan, that increase will range from 86 cents per month for the employee-only plan, up to $2.34 per month for the family plan. And all benefit changes, including those increased dental premiums, will be communicated to members in advance of May open enrollment. I do have a brief update on our participating groups as well. So the SBO has an annual deadline of March 1st for any changes to enrollment from our participating groups, which have the option to participate in the state's medical, dental, and vision plans. So for FY26, there were 68 participating groups. That consists of municipalities, towns, DSWA, fire departments, etc. And the following changes will be made for FY27. The town of Ellendale will be joining the group health insurance plan for all groups. That'll be medical, dental, and vision. And they have 2 employees who would be joining that plan. For the town of Wyoming, effective July 1st, they will be joining our vision plan. They are currently enrolled in medical and dental and have 16 members. And also effective July 1st, the town of Ocean View will be terminating from the group health insurance plan. They currently participate in medical and vision, and they have 62 members. All other participating groups will remain the same for FY27. Any questions before I move on to legislative updates? Okay, great. So there are quite a few bills that are moving through the General Assembly that would impact the FCBC and the group health insurance plan. However, today I really just want to focus on one bill that was recently filed, and Kristen will be sharing with the committee more detailed information on all relevant bills, including their status in the coming days as the session has returned. So for your awareness, on March 5th, Senate Bill 1 was filed. This bill has 2 major components that impact the group health insurance plan and the FCBC. So the first being that beginning in fiscal year 29, the GHIP must provide coverage through a carrier whose payment for covered services does not exceed 250% of the Medicare reimbursement rate for comparable services. So essentially, this is capping the amount the GHIP can pay providers for healthcare services at 250% of the Medicare reimbursement rate. Additionally, in this legislation, GHIP members may only be charged co-payments, co-insurance, and deductibles specified by their health plan, as well as based on the provider's network status. and providers cannot bill members for amounts above the carrier's allowed payment. So essentially, this protects GHIP members from balanced billing practices. And in the legislation, it states that if no comparable Medicare reimbursement rate exists, reimbursement for these services will be determined using Medicare rates for similar services as reasonably determined by the State Employee Benefits Committee. So for this component, for your awareness, not all billing codes have a Medicare reimbursement equivalent. So typically that would be things like pediatric services, labor and delivery, that does not have a Medicare billing. So this language would allow the SEBC to approve what is considered reasonable payments for those services. Again, using comparable rates when already available. There is a notable exemption in this legislation. So any providers that participate in a state or federal global budget model are not subject to the 250% of Medicare cap. So this would be something like the CMS Ahead model, if you're familiar, which is already being explored for Medicaid and actually even the VHIP through the Delaware Healthcare Commission and Primary Care Reform Collaborative. The second piece of this legislation focuses on primary care transformation and investment. So again, beginning in fiscal year 29, the GHIP must increase our primary care spend by 1% from the higher of the prior 2 plan years, and then increasing that spend by 1% annually until we reach 11.5% of our total medical costs being for primary care. So currently what that looks like, we're just below 6% for primary care as a portion of total medical expenditures. And primary care investment can be increased and achieved in numerous ways. So primarily that would be increasing reimbursement from primary care services. So just paying more for those services, prospective or capitated PMPM payments, value-based payment models, shared savings programs, and in quite a few other ways. So currently, the Office of Value-Based Healthcare Delivery under the Department of Insurance leads this work for the state's commercial market. And this bill would now include the GHIP as well as Medicaid in those spending requirements. So just to very quickly go over some fiscal projections from the SBO and from Willis Towers Watson, the SEBC's actuaries. There is a cost and a savings component to this legislation, right? There's 2 pretty significant parts. So focusing just on the primary care piece, that increase to 11.5% over that 5-year period is expected to cost the state $136 million. However, the projected savings to the GHIP via that Medicare pricing cap would be about $238 million in that same time frame. And we also expect some savings due to improved health outcomes from improved and increased primary care management. A low estimate of that would be about $57 million. So when you net all of those together for FY29 through FY34, which is when we would hit that 11.5%, we project a net savings to the GHIP of $159 million, should this legislation pass as currently written. Any questions on Senate Bill 1?
Mr. Chair.
Sure.
Not necessarily a question, just a comment. This is sort of a continuation from SB 120. Governor Carney, when they passed the value-based healthcare bill, well, after he signed it, he turned around and handed it to me and said, "Here, Trini, handle this." And we did bring in $50 million into primary care last year, and right around that number over the last couple of years, which premises to keep primary care solvent, so that fewer and fewer doctors will go to the hospital. We've been talking about this for years, right? And so this will see significant savings. It's going to your point, it will be some costs, but there's a lot of things that this will do. It'll enhance reimbursement and quality. It will ensure successes and efforts and address workforce shortages, stabilize independent practices, support rural providers, reduce disparities in chronic disease outcomes, strengthen prevention. Did I mention it was going to save money? And would expand, moderate hospital prices. And this is, I think some folks think that the DOI, the DHA are this kind of battle over this effort. It's not dissimilar to 350, although Hospital 350, although this is just a different approach. You mentioned global pricing. Currently, Nemours has a global pricing model. We're still looking at that because that might just be for a certain payer. But this is the beginning. This is the start. And when you have, I've already seen things on Facebook and commercials how keep politics out of your healthcare. Listen, we're trying to do precisely what the bill told us to do and build upon it. And so I don't want to go too much longer, Mr. Chair, but before people start saying that this is the worst plan ever or ideal ever, or they'll ever research it, learn about it, read about it, because it does a lot of wonderful things. If we want to be serious about bending the price curve, I know Jeff talks about that all the time, this bill will do that. There will be a cost, so there are upfront costs, no one's denying that. But pay close attention to what Willis Towers Watson said. I think he said $100 million savings or more potentially for the GHIP. This is what we've been talking about. And this gets us closer and closer and closer to our goals. So thank you, Mr. Chair. If anyone has any questions, it is a DOI bill. I don't pass bills. I don't vote on bills. Our department does it. But we have written it through our Office of Value-Based Healthcare Delivery. This is what we were tasked to do. And we believe this is the appropriate path forward. Be happy to take any questions about this.
Mr. Karen Peterson.
Yeah, any question, knowing from other states who have done this with the reference-based pricing, knowing that 100% of Medicare allowance gives a profit to the facility, where did the 250 come from?
In some cases, some of the hospitals are paid well in excess of that. And so that's why they're fighting us. So 250 was a number that our team, our actuaries put together so that it would be, I'll give you an example. St. Francis gets paid well below that. Tidal Health gets paid well below that. So it'll sort of level the playing field. So they'll make a little bit more, and the large hospital systems in the state will take a haircut. But they still charge facility fees. They still charge 800% of your prescription drug costs. There's other ways for the hospitals to make money. It's not, if they take a haircut in this regard, I'm not saying they would make it up necessarily, but I don't think that, I don't throw around words like hyperbolic, but if you see some of the stuff that's being put out, that they're going to have to cut staff and that people are going to be out of jobs and we're going to lose our status.
Right.
And this is just regurgitating what they said last year. And you know what? So let's come to the table. Instead of saying, this is wrong, this is wrong, this is wrong, this is wrong. All right, let's have a conversation. Because I think, we always get criticized for the Delaware way, I guess, saying or terminology, but that's the town talk.
I just saw a video from Christiana Care last week. I was asked to look at where they charge a patient $13,000 for a Prolia shot that you can get on the open market for $1,800. A site facility charge added to the office visit charge, a charge of $71 for taking the patient's blood pressure, which used to be standard when you went to the doctor. All that was in a bill that I looked at last week. That's outrageous.
Yeah, unfortunately, people don't look at their ZOBs, and so they don't really, in many cases, their insurance covers it, so they don't really think to look at it. But you're absolutely right. I mean, they will make it up in other ways. They've been creative over the years, and I think this is just a way to do precisely what we've been talking about for years.
I think there's some things that we can do too, as we're coming up on the RFP for the TPA, like that the facilities charges
Facility fees, significant.
and bundling that Bill's always talking about. There's a lot we can do in there too.
Yeah, it's not a done, the SB 1's not complete. And so I think we have room to come to the table. That's what we should have done. All right, thank you, Mr. Chair.
Real quickly,
Yeah,
I just want to thank the insurance commissioner and his office for the work in what may be the understatement of the day. I think this is long overdue. But I also want to thank Stephanie and everybody that got us that cost estimate. It's incredibly helpful to have that fiscal analysis or financial analysis and have it so quickly. Yeah, I just really appreciate that because, we're going to get asked about this, and knowing that kind of detail is going to be helpful in answering questions and just engaging people. So thank you for doing that so quickly.
All right, so important discussion there. I think Yvonne has her hand up.
Thank you. Just a point of order, Mr. Chairman. Can everyone say their names before they speak? Because even when you come back with a comment, it's just difficult to remember who's speaking.
Thank you for that, Secretary Gordon. All right, so I believe we're done with the director's report. We now move to agenda item number 5, which is the election of a vice chair. As Director Hartis reported at the last meeting, the SCBC is required to annually elect a vice chair. I've received outreach from 2 members, Treasurer Colleen Davis and DSEA Representative Jeff Tashner, with their interest in serving as vice chair for the upcoming year. Are there any other eligible committee members who are interested in serving as vice chair? Seeing none, I will now allow each interested member 2 minutes to tell the committee why they would like to serve as vice chair. In alphabetical order, my last name. We'll go with Colleen Davis first, followed by Jeff Tashner. Colleen?
Thank you so much. For the last 7+ years, I have been serving as the state treasurer, and I've been truly honored to do so. I've also, prior to that, led a varied life in my professional career. As many of you know, I practiced neurosurgery as a PA for about 18 years. I moonlighted in the emergency department and staffed a level 1 trauma center. I saw people at their worst and truly understand what it means to ensure that we have care that meets the needs of critical situations. And so I've dedicated my life to serving, and I want to continue to do that. After providing direct care, I was also a consultant for major hospital systems across the US. I had contracts in 17 different states, and I've seen what so many other states and communities are facing when it comes to meeting the demands of healthcare and those rising costs, as well as ensuring that we're balancing budgets and we're not leaving people behind. It's why I've wanted to serve. It's why I've stepped forward to continue to serve as the co-chair here. And I'll just say that I come from a family that has a long history of union membership. I'm the daughter of the president of the Iron Workers in Manhattan. I'm sorry, I'm the granddaughter. And when he passed away at a very untimely date, he and his wife, his wife and his children were cared for by the Brotherhood to the end of their lives. And his wife lived to be 97 years old, and she retired in Ocean View.
2 minutes is up. That's it.
Okay, my apologies,
Jeff.
but thank you so much.
Yeah. Let me just talk about why I decided to throw my name into the situation. First of all, you've all heard me talk about my history with the GHIP, but to unpack that, it goes back nearly 20 years when the public sector unions brought in an outside consultant to do a review of the plan. Then transitioned to 2011 when I led the negotiations with the Markell administration around pension and health care that maintained benefits but saved over $500 million over 10 years. Their projections, not mine. 2015, 2016 on the Joint Task Force to study this plan, and then appointed to the SCBC in 2017 for a 3-year term that ran 5 years because I was extended to an appointment and held on through COVID. I left when this body was expanded to step out to the RHBAS, was brought back a year ago. So I have a lot of history, maybe more history with the plan than anybody that's on the committee currently. My focus, as was alluded to already today, is on price. We pay too much for medical and pharmacy. I want to continue to work on that, not only for the plan members, but for the state. It puts pressure on the state budget and for the citizens and the taxpayers of Delaware. If we lower prices, everybody benefits. My current appointment runs through February of next year. So as I thought about this, quite honestly, this may be my last chance to serve in the role. You know about the appointment. What you don't know is my contract with DSCA runs until August or September of 2027, at which time I'll be 65. So I don't know what's going to be there for me beyond that. This may be my last chance. I think the fact that I represent a union, but I was appointed to represent the active members sends quite a message if the leadership of this committee is balanced between the budget director and somebody here as the representative of the plan members. So I hope I got your trust and respect, and I ask for your vote.
Yeah, awesome. I'd like to thank both candidates for their interest in serving this high-paid job as vice chair of the SNC. I will now ask for a roll call vote. Danielle will call your name. Please indicate who you voted for vice chair.
Director Maxwell,
Colleen Davis.
Secretary Gordon,
Love you both, but Colleen Davis.
Lieutenant Governor Gay,
Treasurer Davis.
Can't vote.
Yeah, good.
Oh, Treasurer Davis,
I'm going to vote for myself. And thank you so much for the confidence.
Commissioner Navarro, Secretary Young, Treasurer Davis, Deputy State Court Administrator Ashley Tucker,
Treasury Davis.
Jeff Tashner,
Vote for myself.
Paul Bumbach,
Mr. Tashner.
Karen Peterson,
Jeff Tashner.
Bill Oberly,
Jeff Tashner.
seven for Davis.
Colleen, you're stuck with me for another year. Thank you both. All
Thank
right.
you.
Moving on to, we need to go into executive session pursuant to 29 Delaware Code, section 10004B6. Discussion of the contents of documents excluded from the definition of public record pursuant to 29 Delaware Code 1000202 and 06 and 29 Delaware Code 6981D3, the Health Data Warehouse Request for Proposals, Proposal Review Committee recommendation. So I will entertain a motion to enter executive session.
So moved.
In a second.
Second. I second. it.
Motion in a second. Does anybody have any discussion on the motion? All those in favor say aye. Those opposed?
Bye.
None? All right, we will be back shortly after our executive session concludes. All right.
You turn that up a little louder. It's a volunteer to move action. All right.
We're gonna move on to agenda item number 7, which is the approval of the Health Data Warehouse Request for Proposal recommendation. So I will entertain a motion to approve the Health Data Warehouse Request for Proposal Review Committee recommendation as presented in executive session, and the SBO to begin contract negotiations with the recommended vendor.
So moved.
I'll second.
Any discussion? Seeing none, roll call?
Director Maxwell,
Yes.
Secretary Gordon,
Yes.
Lieutenant Governor Gay,
Yes.
Treasurer Davis,
Yes.
Commissioner Navarro,
Yes.
Secretary Young,
Yes.
Deputy State Court Administrator Ashley Tucker,
Yes.
Jeff Tashner,
Yes.
Paul Bumbach,
Yes.
Karen Peterson,
Yes.
Bill Oberly.
Yes. Motion approved. All right, moving on to agenda number 8. We have under fiscal year 27 planning, A, approval of FSA dependent care contribution max increase, and I believe we have Heather here to walk us through that.
Yes, good morning.
Morning.
Okay. Moving on to the next slide. All right, so a little bit of context for today's discussion. So we know that during the February 13th meeting, the SEBC was provided some background and overview on the FSA dependent care maximum increase. We do have one minor clarification update to slide 4. You'll see it highlighted in magenta font. We replaced that term childcare with dependent care. And then today, the SEBC is to vote on whether to increase the FSA dependent care maximum to $7,500.
Any committee members have any questions? I will entertain a motion to increase the FSA dependent care. Oh, sorry, Lieutenant Governor.
Thank you, Mr. Chair. Not a question, just a statement that this is obviously a good move nationally, and I'm glad that this is under consideration. Just want to note that the $7,500 is really still just a fraction of what full-time care costs for a person for a child 0 through 5. And so as we continue to think about ways that we can help our plan members with benefits, I think we should think about dependent care and, of course, elder care, which I know is somewhat involved depending on the definition. So thank you to the members of the committee for considering this morning. I'll be obviously an enthusiastic yes, and I'm happy to make the motion to approve the increase.
That you guys are so efficient today. Everybody knows what the motion is, right? And we have the motion and a second. I'll call for a roll call.
Director Maxwell.
Yes.
Secretary Gordon.
Yes.
Lieutenant Governor Gay.
Yes.
Treasurer Davis.
Yes.
Commissioner Navarro.
Yes.
Secretary Young.
Yes.
Deputy State Court Administrator Ashley Tucker.
Yes.
Jeff Tajner.
Yes.
Paul Baumbach.
Yes.
Karen Peterson.
Yes.
Bill Overly.
Moving along, we have approval of changes to weight loss medication coverage. I'll turn it over to Willis Todd Watson. Brian, joining us.
Thanks, Director Maxwell. Brian Stitzel from WTW. There were a few follow-ups we'll go through quickly from the February 13th meeting relative to questions. We can run through the options again, specific to either the elimination of GLP-1 for weight loss or various copay changes that were proposed, and then ultimately have a committee vote on the options. Following up from the February 13th meeting, question was raised as to whether or not better rebates could be negotiated with Novo Nordisk relative to Wegovy, which is the covered GLP-1 for weight loss under the CVS formulary. CVS continually, regularly negotiates with Novo. At this time, SBO reached out directly to Novo to see if any additional concessions could be made, and at this time, Novo's unwilling to provide any additional financial support relative to the price or rebates. One of the other topics that was discussed relative to the potential increase in the current $32 copay for members for a 30-day supply. Novo currently offers a copay assistance program up to $100 per month. And the question was raised as to whether or not Novo could guarantee whether that program would remain in place for the foreseeable future. Again, SBO discussed this directly with Novo. The programs generally run on a calendar year. So the program will continue to run through 2026. and then they make their decisions annually. But at this time, they're not willing to guarantee that the program will continue beyond 2026, although it is likely. Additionally, a question was raised as to whether or not pharmacy member copays could be variable based on employee salary, looking to address affordability as an issue. While CVS could set up a structure to administer this, there are a number of barriers. SBO does not get salary information from non-state groups, which would make it impossible to administer and would not be consistent with the way that the out-of-pocket maximums and copays are administered under the medical plan. And additionally, employee salary is not a full indication of household income. So there could be some inconsistencies between people solely based on their state salary. And then lastly, there are very, very, very few employers who have variable plan design features by salary, likely probably less than 0.1%, where employers do tend to vary plan features by salary. It's usually based on the upfront employee contributions that employees pay, not the individual plan features. Lieutenant Governor Gay, you have a question?
Yeah, no, I just a little bit of a comment, and I appreciate kind of the normal status quo commentary, and I think we get a lot of that from you all because you have a market awareness that those of us who do this as a part of our portfolio and not the full portfolio don't have. That being said, we are in a time of unprecedented change in the healthcare market, and I just think that sometimes it's more helpful to think about what's possible in different spaces and understand what the specific barriers are to doing something that is unusual rather than just saying it's unusual. And so I want to make sure that we in these spaces are being open-minded. And I'm not here to say that WW isn't being open-minded, but I don't think that that's necessarily being translated in some of these meetings. And so thank you for the data, like the 1%, that's helpful. And then in the future, as we kind of consider innovative approaches to our delivery of healthcare to our employees, let's really start understanding what some of the structural barriers are, because that will help us understand whether or not it is possibly innovative in those spaces. And I appreciate this rundown. This is helpful from last meeting. Thank you.
Sure.
Before you continue, Brian, Commissioner Navarro has a comment.
Thank you, Mr. Chair. Brian, I just hope that everyone was paying attention when you said that CVS was not willing to guarantee sort of the future savings or future programs. No vote.
It was no. Yeah.
It would not allow us to purchase directly from the manufacturer, sort of, foregoing the PBM. Look, under no authority whatsoever, I called Eli Lilly to see if they would be willing to do something similar to this. I know some of the executives there from different interactions over the years, and they immediately said if we would do that for Zepbound, was one of the drugs that was dropped off the formulary. I'm still angry about, trying not to curse. And they indicated that they would do a cash price of $494 today for the state plan. Forego the PBM. Now we still have to have a TPA to administer it. So the point is, they are no longer part of our formulary, right? So they want to be back. And I think that we could even negotiate even a better deal than that. And I hope that, moving forward that we're able to do that. PBMs you have to be careful for your audience, because I said this at a conference that PBMs were the enemy. And there were a number of PBMs in the audience, so that didn't go over very well. But I mean, it really has cost us tremendously over the years. A billion-dollar industry that provides nothing. They don't sell anything. They really don't provide any service. They just fat in their pockets. And so I was able to, just by making a phone call, the first offer was, we can essentially charge the state half. Stephanie, if I'm wrong, but I think it's around $1,000.
The current net cost, or sorry, the current acquisition cost for Wegovy is $1,339.
Yeah, so that's before rebates.
Correct.
Yeah. But I do think that we could potentially do even better. That was the first offer out of the gate. So I just wanted to share that we don't forget what they're saying now as we look to the future.
Bill Overly?
Yes, Bill Overly. And again, thinking outside the box, I had mentioned earlier about carving out of the PBM contract GLP-1s, and I think I was advised you can't do that. And I'd like a further explanation on that. Because, I mean, through our TPAs, we do carve-outs. Lantern, I mean, that's a carve-out. So I'm trying to understand why we could not carve out the GPL-1s and bid them separately.
So this is Director Hartos, we can, under our current contract with CVS, we could carve out GLP-1s. Where, and it's not necessarily a barrier, but a consideration is, yes, we would have to likely procure for those. So to Commissioner Navarro's point, we've also had conversations with Eli Lilly, and they're, at least, I think the last time I spoke to them was probably about 6 weeks ago. So things may have very well changed. It's a very quickly evolving market. But their carve-outs were directly through other TPAs, in which you can get that direct to manufacturer price with an additional administrative fee associated with that. And of course, the culmination of those administrative fees would exceed the $150,000 threshold. So there would need to be a procurement for that, but we absolutely could, we do have the ability to carve out GLP-1s from the PBM and to contract directly, but again, it would have to be ensuring that we're in compliance with the state's procurement.
As a follow-up, I was speaking in the context of the new RFP for the PBM.
Yes,
So you would have an RFP for the PBM, a separate RFP for GLP-1s.
for an effective date of July 1st, 2027.
Right.
That could absolutely be considered.
That
That
makes
would
the
need to
whole
be developed.
situation more competitive.
Yes, there would be a lot of administrative capacities to develop that RFP, but hypothetically, yes, absolutely, that could happen.
Well, quite honestly, we can continue to do the same, or we can go into the marketplace and try to get the free market to enable a better price as an end user.
So what I will just caution, because I've had these discussions, everybody's working towards the same goal,
Oh,
which is try to get the best price and provide the benefits to our population. What you have to be careful is this market is relatively new. And so under our current existing way we provide this benefit is that we go through this prior authorization model where the PBM is doing prior auths, right? This market, when you're hearing the price that Commissioner's talking about, it's not so much going through this prior authorization. It's kind of more like the direct to consumer, direct to employer. And so you don't have that infrastructure or the cost when they're talking about the drug of having that prior authorization kind of infrastructure in place. So that I just want to make sure everybody's aware. Not to say the market won't move towards that, but right now it's not there. And so I just want to caution everybody that there's always a part B in this conversation. So I'm not against putting it out there and figuring out what's the best way. I'm just saying the market continues to change.
Right.
And so we obviously have to adjust to that.
Yeah, and I'm certainly not suggesting this is a panacea.
Uh-huh.
What I'm suggesting is we've been doing business a certain way year after year after year, and we don't always end up with the desirable outcome. So why not look at it different?
Secretary Young?
I just sort of building on Director Maxwell, what you were just saying, Director Hardos, I wonder if you could talk about this, like what it would look like from the patient and the doctor's perspective in a scenario like that. I think what we're saying is that there would be like 2 insurance cards, one for most of the benefits and one for the separate benefit, and 2 entities administering prior authorization if we ever got there. So like, I think you're saying the doctor would have to send their prior authorization request to Metformin to one place and for the GLP-1 to a different place, and consumers would have to sort of present those 2 cards, and they might have different pharmacy networks. And I just want to make sure we're thinking about all of those complications for splitting things up like this.
Correct. Thank you. This is Director Hartis. So quite frankly, a lot of that would be yet to be explored. We have never carved out any type of drug before under the
Exactly.
health plan, right? So, but yes, your concerns are definitely reflective of my thoughts as well from the member standpoint. So of course, there would be that additional barrier of having another TPA essentially to be going through. Whether or not prior authorization is a part of that would be a consideration on the provider side and what that submission would look like. As well as the administrative support from the state side would look very different to essentially administering another contract and potentially directly contracting with a drug manufacturer. We have never done that. So I think there would be a lot more research and work we would need to do to be able to speak to what that would look like. Because we've never gone through that practice in the state before.
Mr. Chairman?
Karen Peterson.
Yeah. What I'm hearing is that maybe someday, but not now. Is that what I'm hearing?
This is Director Hargis. I wouldn't say that at all. I think the upcoming RFP for the PBM, which we are voting on today, does have those caveats in there of the carve outs of certain medications. And again, under our current contract, we can still do that. And it is absolutely something that the SCBC can explore. And if the interest would be to explore that alongside the PBM RFP and to administer that RFP, we can absolutely start that process to see what it would look like. Again, it's just a very new process that exists, states and employers in general, because again, I think we need to remember that even though we are the state of Delaware, we are an employer-sponsored health plan, right? So it's a little bit different than Medicaid and the other commercial population, right? We are an employer, and maybe WCW, correct me if I'm wrong, but I'm not aware of any employer that directly contracts with drug manufacturers.
Maybe we can be the first. Mr. Chair, if I may consider, I would hope that we could pursue this for July 1 or whatever, June, to pursue this, because this could make a huge difference in terms of how I plan to vote on this whole thing, whether or not we're able to do this. But another option that we haven't talked about is the whole idea of the putting folks on a maintenance drug after their first year on a GLP-1. There was a recent study that showed that after the first year, people can go on a metformin or any of those in that class of drugs and maintain your weight loss without having to continue the GLP-1 drug. And that would, if you look at how many of our folks on the drug right now are at 1 year or beyond, imagine what kind of savings there would be if we could keep their weight off for $4 a month copay instead of these $120, $250, $300 a month copays we're talking about. I just think that's something we should be discussing. And I don't know if WTW is familiar with that study, but I think it's been distributed to everybody on the committee. That's where they found that not only did you maintain your weight by switching to a metformin or one of those AOM drugs, as they're called, but you continue to lose weight on them. I think it's something we could consider and save tens of millions of dollars right off the top. And Trudy, I don't know if you're familiar with that study or not.
Yes, what I'm ready. I don't mean to.
Commissioner Navarro?
Yes, Commissioner Navarro, thank you. So I know that we would have to go out to the RFP process, but there's an entity called Flight Health. I met them at a conference in DC a few weeks ago. And what they did in, I think, Connecticut, is they manage this program. It's a TPA, which happens to be a TPA of Eli Lilly. I just confirmed that. Doesn't mean we have to use them. But their first year, they saved the state of Connecticut millions of dollars, making sure that people were on the right plan, making sure that maybe not everyone needed a GLP-1, making sure that that people, that they're physicians who work for Flight Health, who actually this is what they do. So it sounds like a giant lift on the state side, but there's TPAs out there that will do that. And the last comment is, I wrote it down, so I want to make sure I say it right. But just to mention that no prior authorization does not necessarily mean no control over utilization. So I just want to make that point as well.
Mr. Chairman, if I may just
Senator Pierce.
add to that, that's, I wanted to follow up on that as well. It's not like it's the wild, wild west. I mean, doctors are writing prescriptions, and hopefully it's your primary care doctor who thinks that it's in your best interest to take these meds. So it's not completely without authorization or thought. But I really wish we would, consider the whole maintenance, even if we did it as a pilot program, to say, and if you went off on these maintenance drugs at $4 a month, and you started to put the weight back on for whatever reason, then you put you back on the GLP-1 drugs. But it's been highly successful. So I don't know why we wouldn't think outside this box.
Lieutenant Governor?
Thank you. I just want to make sure that there's been a lot of suggestions, and I really appreciate the conversation and the interest in pursuing something where we can move closer to our goals of reducing costs, but making sure that we are providing individuals with the medications that are improving their overall health outcomes. And so I just would like if Director Hartos perhaps could say where we are in the process right now. We're at March 9th, and the plan was, any new plan or third-party administrator work would begin on July 1. What that process could, in theory, look like, because I believe I heard you say it is feasible. And so perhaps, and I don't mean to cut off the conversation, but perhaps you could also let us know, should we move forward with talking about the options in front of us as a as a backup to potentially a new plan of seeking out a one-on-one relationship with one of the providers of this medication. If that's not clear, I'm happy to rephrase.
Thank you, Lieutenant Governor. This is Director Hartos. So I would want to be clear, the earliest in which a new RFP and a new contract could be implemented would be July 1st of 2027. So not 3 months from now, it would be next year. And that would be coinciding with the PBM RFP.
Understood. Thank you. And so you do believe that is possible. And so that this conversation we're having right now has no bearing on the decision in front of us related to the options for July 1, 2026.
Yes, because the earliest implementation through our procurement process for a new program would be fiscal year 28. The discussion at hand today is for plan design changes for fiscal year 27. So absolutely there, that's still a strong part of the conversation, but there would not be a scenario in which we could implement a new contract, whether it be through our current TPAs or through an RFP process for a program effective July 1st, 26. The earliest would be July 1st, 2027.
Thank you. And I appreciate you being very explicit about that, because there's a lot of people listening, and I want to make sure that we are very clear always about what we're able to do in the time frame we're able to do it. The other thing I just wanted to note is, and I'll lower my hand so I'm not, is that I think we should focus on our ability to financially implement or impact the negotiations that we're having. I greatly appreciate the alternative care mechanisms that have been discussed, and I think there's a lot of doctors who are learning a lot about this. But as we saw when the formulary changed, the specific medications that individuals are taking in consultation with their physician, I think should be a conversation that's happening with the patient and their physician. I think we here in this room should be focused on encouraging any options for care, just like Senator Peterson mentioned, right? Encouraging that we would have coverage for different options for care. And we should also be looking at our negotiating position. And so I just want to make sure our conversation, I want to make sure we carry on what we need to do today, but also that we perhaps carve out time in the future so that we can have this conversation about alternate methods, which I greatly appreciate.
Treasurer Davis?
My question was, along the same lines as the Lieutenant Governor's. I think we have a lot of things that we're sort of discussing on an ongoing basis, whether it's direct contracting, how TPAs are impacting us, elimination of prior authorizations, the shift to maintenance medications. and how all of these things from a global perspective impact participants. What would be immensely helpful would be to possibly, sort of allow folks to have this discussion, but set aside some of those topics and just sort of give us the clarity that like that's not something that we can consider in the here and now and today, because I almost think that we're all on this road trip together in a vehicle that's running out of gas, and we're sort of debating as to which place we stop to fuel up, and we've got to fuel up, right? So I think that we have to really clarify what are the things that need to be addressed today, and then again set aside some of these other topics because I think they're immensely important that we tackle them.
Jeff Tashner.
I'm prepared to make a motion if you're ready to entertain one, sir.
Are we ready for motions, or do we want Brian to continue his presentation? I'm just asking the committee members. Oh, Paul Baumback has his hand up.
Yeah, I have comments for later slides here that I've been holding off waiting for that slide to come up. So Mr. Tashner, is the motion related to which one of the presented options? If so, I'd like to get some comments in before we get to that.
It is, and I'll let him go through the slide deck just so that I'm queued up and
Yep.
in line.
Yep.
I mean, I can just go to my questions and lead Brian through the slides if that's, Mr. Chair, it's up to you how you'd like to go.
You can go have your questions answered.
Okay, so the next slide, and if you can have the slide number shown, if you can make that happen, that would be helpful. So the next slide talks about, the next slide, please.
Next one.
Slide 7, I believe.
Yep.
Okay, the last line says it does not meet SCBC objective of a 0% rate action for fiscal 27. What exactly is, quote, the SCBC objective of 0% rate action for FY27? I don't recall the SCBC voting upon that. I would certainly understand if some members of the SCBC have that as an objective, but I did not believe that was an SCBC objective. Am I incorrect on that?
I don't believe it was something that was voted on. I think it was just verbal commentary that the goal was to mitigate the rate action for FY27.
Is it correct? I believe it's correct that medical costs are rising maybe 4 to 6 to 8% in 2025. It seems to me that even a 0% objective is counter to our mission you can't get something for nothing, and I don't think we can ensure access for high quality and safe healthcare while managing the cost for both the GHIP and its members while going with a 0% increase, especially when some of the presented options are ones that increase the cost for the individual members. I think that there's some framing here that is presumptive, and I want to raise that at this point. On slides 7 and 8, there's the talk about the doubling of I think there's talk about mention the cons, the number of members who determine they cannot afford the new costs, stop coverage, and experience the cons. I think that's a con. If you have people who are priced out because of these copays that are proposed, we've got health negatives. And I think option 1 pointed out the positives of maintaining that if we maintain the current coverage, we would have notable positives regarding health outcomes and also later costs, and yet that's not listed in the cons of some of these other options. I think there's some incompleteness in the presentations. On slide 9, let me see where it went. The last, next to last bullet saying can be fill the prescription without review and approval. I think you mean to say by the PBM, which some members seem to understandably have a negative view of this prior approval process, but we certainly have the healthcare physician healthcare provider who's providing the prescription as providing review and approval. It's a second level of approval. Sometimes people view as being intrusive. The review and approval mentioned here, I think, should be clarified to mean PBM approval. And slide 10. And this is the thing about I know we had the phrase about tic-tac in a previous meeting. The health consequences, no clinical oversight. I would say that if these two cons, numbers 2 and 3, or the second and third one and under cons, if there's such a large issue, then I would hope that our DHSS is taking this on with the General Assembly and looking for legislative address for this. And if not, perhaps these aren't large enough to make this list. I think we've got some inconsistency in the presentation of these two issues versus the actions of the rest of our state government. So I feel that we have a imbalanced and a bit of a biased presentation in some of these options, and I find that pretty frustrating. On my last point on slide 18, we have, and if you add it to 19, what you actually, maybe it's just 18. What you have is that 65% of states are not in various phases of discontinuing coverage. And I think that's important. When you look at the whole scale, yes, we see the list of the ones that are doing some adjustments, but the other states that are doing nothing, maintaining their status quo, I think is important in our decision making. And that's it. Thank you so much.
Controller General.
Thank you. I just want to be clear, because as we're talking about these rates, once again, having just sat through 6 weeks of Joint Finance Committee budget hearings, that based on the budget that was proposed in January, there is no money currently in the operating budget for premium rate increases for the state employer share. So if the vote on the GLP-1s is to continue coverage at some rate, not only will we have to figure out how to make up that gap in the operating budget, it will also mean that everyone that is in the plans, all active state employees and retirees, will see a premium rate increase. Is that correct?
That's correct.
And how much money will need to be added to the operating budget if the vote is to continue coverage as it stands right now?
I believe the general fund cost is $31 million.
Got it. Thank you. So again, just want to make sure that everyone understands, having worked with state employees for a long time, they appreciate it when you level with them. And I want them to be sure that they understand there will be a premium rate increase coming, depending on what happens with GLP-1s here.
Lieutenant Governor.
Thank you. That's why I'm so glad always that both OMB and Controller General's office are here to provide the perspective, specifically because of the interplay with this committee and the choices of the General Assembly in crafting the budget for fiscal year 27. And I want to just try and understand how the GRB recommendation that was just described, can we explain how that relates to this committee's votes on the smoothing that we took last year, so that folks who are watching can understand kind of how these decisions are working together in order to come to a final outcome as to what either the increase for the state share or the increase for the employee share would be.
I have to unpack there. I'm trying to, which specific do you want me to? So each of these options have some variable in them as far as the implementation. Like if option 1, eliminate coverage for GLP-1, there would be no need for rate action because the cost associated with covering GLP-1 medications for weight loss more than covers what the general fund need would be for the upcoming year to sustain a 4.2% rate increase, right? Mm-hmm. Then you get into the other options that have been presented, which, I take exception that we're saying this presentation is biased because I think I've included a number of options here from the committee's standpoint. as to what ideas were held out there. So each one, depending on the level of copay, you can reduce the rate increase that would be required to apply to the participants for the upcoming fiscal year.
And when you say reduce, do you mean from the 4.2 that was voted on
Yeah.
Correct.
here?
Yes, that's correct.
Okay, great. So I think, and that's what, and I appreciate you everyone being really clear about it, because for those folks who are watching, right, it's not from 0 to 0. It's, I think what my understanding is that the presentation is demonstrating the change from the recommended increases that this committee already addressed over a 3 to 4 year cycle.
That's correct.
Thank you. I appreciate that.
Now,
Director Maxwell, where would you like to go?
could you just confirm on that list of states, the 14 in the box, does that mean all the other states aren't really providing GLP-1 coverage for weight loss?
We'll have to take that back, because there may be states who, this is a list of states who have discontinued. There may be other states who never covered them in the first place, so we'd have to take that back.
I'm talking about the first box up at the top there. It says, while state-specific weight
Okay.
loss has been in flux, it appears 14 states are
Okay.
currently.
Which would mean the remainder do not.
Okay, I just want to make that to be a point of clarification. If we could also go back to the prior authorization, I believe there is a figure on the page that says over 7,000 of, were denied because of our prior authorization. So we can go under the hypothesis that a doctor is prescribing this, but at the same time, they're prescribing it not within the criteria that we set forth in our program. So just want to be clear about that, which if those 7,000, there could be some duplicates. I think the footnote mentions that, but that was literally more than double our population today that we currently cover. So just want to be clear about that. And I do have my tick back. So is there anything else we need to cover as far as the presentation? Lieutenant Governor.
Thank you, Mr. Chairman. I just want to make sure that we understand also how we got here today, where it seems like, and I view it as a remediation of our original intention of how to cover these drugs. And I note that, and maybe Brian can give us just a quick reminder of the difference between the annual spend versus what was first predicted when this decision was made by a prior SEBC to cover GLP-1s at the $32 copay.
So at the time that it was approved for coverage, which was for FY24, the estimate at the time from CVS, I don't have the exact figure, but I want to say it was, I think, $1.4 million was the expectation in gross spend before rebates. That actual number was like $13-14 million, which has ballooned. So you can see the numbers here are actually after rebates. So the net cost to the GHIP after the rebates from Novo, and you can see that for FY27, that projected cost is nearly $60 million, expected to grow to 70 and then $80 million over that 3-year period.
Thank you. And I think it's very evident that we have been ill-served by those projections, and that of the past SEBC made, I think, a decent and strong decision to, again, provide medications to individuals that were going to greatly impact their health outcomes in a positive way, and did so believing that we could do so within our bounds as a state. And so I think when we when we move forward and we have additional projections and we think about ways that we incorporate other medications, Brian, I'm interested in kind of the due diligence that WTW did in 2024 related to the 1.4 million. And, you know, maybe you can let us know what kind of interrogation you did at that point. You know, I'm asking somewhat of a rhetorical question because it's neither here nor there right now. But as far as the work that we are doing day to day through SBO, through this committee, the funds that we are contributing to ensure that we are paying our vendors, including CVS, including WTW, to be so ill-served by those projections now puts this committee in a place where we have to make this very difficult decision. And I'll underscore again how much we have heard from our constituents, how much we have heard from our state employees about how beneficial these medications have been for their overall health. And I believe there are long-term benefits for our financial well-being as a state plan as well. But again, we have to do something at this point in order to make healthcare affordable for everyone in our state as well. So I really want to make sure that we go with caution into making vast changes to the plan. And I want us to really consider how we can best be served by the vendors that we are paying for their advice and counsel if in fact we end up at places like this. And so I think that just takes due diligence on behalf of all of us and the partnership with our vendors to make sure we're being transparent and clear with each other. And I thank you for giving me the time to share that because this has been such a difficult conversation and difficult issue in trying to serve our state employees.
Yep. Commissioner Navarro?
So I don't want to get too off topic, but since we're talking about premium impacts, I know that Lois Watson did do a study on SB1 and how that would impact premiums for the state employees. Do you recall that number off the top of your head?
For Senate Bill 1, how that would impact the premium?
Yes.
Not off the top of my head, but I do have that information I can
Does
share.
WTW have it? I think that's important.
Yes, I can pull that up. We had not discussed it. And again, those would be starting in fiscal year 29.
Understood.
Or waiting on that, Paul?
Yes, thank you. I appreciate the Lieutenant Governor's comments about making sure that our decisions are made with as much educated input as possible. I want to take some steps back. That this 0% figure came from the governor's recommended budget, and that was against the advice of the SCBC, which even a smoothing process said we are under assessing the premiums for 2 years because we're going to have a big jump in the third year out. You know, this is the same magical thinking that both governors and general assemblies in the past have done that led to, you know, easy big double digit increases, I think 2 years in a row, fairly recently. And just, you know, wave of a pen saying, oh, so we'll have 0% this year and building it into the budget. It should not, I don't think that should be driving our decisions. I think we should be looking at the GHIP over time. We should be looking at balancing our mission. I think we should be listening to the input, both from the experts and also from our members. And I think we should look at putting a 0% in when we've got a double-digit one 2 years out. It's just fiscally irresponsible in my eyes. I'm not wild about the 4242, and then I've seen two different figures in the stuff for this meeting, 13 and 15%. You know, that in and of itself I'm not wild about, but at least the smoothing says we're taking this responsibly. We're not going to try to steal today from tomorrow. I think we're accepting as a given a structure that's irresponsible. I think we should be sticking to our 4242 and whatever, you know, we've agreed to. It would be after that. Also, I want to note the GLP spending by the figures in the presentations for today's meeting. I believe are expected to be down 30% versus the budgeted level for this fiscal year. We've seen these big price decreases coming just in recent months. So, you know, the world's ending and we can, but we have to strike it to zero and and have such a negative impact on our thousands of members for a 0% wish list really frustrates me as being a very bad way to run the system. Thank you.
Just a few comments. I do have a very good memory. So I remember last year we talked about the smoothing. Mr. Bomback was not a fan of the smoothing model. And he also, I believe, was supportive of a 0% rate increase for the Medicare population, which, like you said, with healthcare costs going up, we can't assume a 0% rate increase. The proposal that's before you, as I mentioned, if we were to eliminate GLP-1s, the savings from eliminating GLP-1s would more than offset any premium increase that would be necessary. So, Mr. Bomback, you have your hand raised again.
Yes, to address what you commented, my comment was it should be higher than 4.2, not that it should be, not that I was against the smoothing. I thought the 4.2 and then a jump was less responsible than a higher than 4.2, and a smaller jump. It was not that I thought we should be at 0. Yes, I did think that the Medicare population, age population, should be at 0 because their rates, they are providing excesses into the GHIP that are used by other populations, and I feel that that is not equitable. And I do believe that over time the SCBC should be addressing that, and I'm disappointed that it hasn't been. So yes, indeed, I do appreciate the record being brought forward. Thank you, Mr. Chair.
Any other comments? Yes. Stephanie.
Thank you. Director Hart, I was just responding to Commissioner Navarro's comments, and then I also wanted to provide a quick response to the Lieutenant Governor's as well. So, Commissioner, you had asked about how Senate Bill 1, if passed in its current form, would impact premiums. And I can read through FY29 through FY34, which is what we projected. For FY29, the decrease to the current premium projections would be negative 2.2%. Negative 4.3% for 2030, negative 6.2% for 2031, negative 8.1% for 2032, negative 10.2% for 2033, and negative 12.8% for 2034. And I just want to note those negative percentage, that's based off of if we're expecting an 18% increase for FY34, you would subtract 12.8% for that. So there still may be an increase, but that's just based on current projections, notwithstanding any other unanticipated changes in the market. And again, if this bill were to pass in the form that is currently written. And I also just wanted to, I believe the Lieutenant Governor had asked about when this vote was, yes.
So per your report, I just want to put this in dollars for folks. Per the report that we saw, we'll save $159 million over the first 5 years of implementation. So we'll have the ability to cut costs without cutting benefits like this, if we're willing to kind of look at the big picture of costs. So it's $159 million. You agree? It was in the report?
Correct. That is the projected savings from FY29 to FY34.
But you're going to the next topic.
May I continue my response for the Lieutenant Governor? Thank you. So regarding the Lieutenant Governor's questions, I did go back to 2023 when this was originally presented to the committee. Coverage of weight loss medications was actually presented as one of 6 plan design benefit changes, and it was actually not recommended by WTW, citing that further study was needed at that time. And the committee voted to cover with utilization management, which was expected to be at the time $1.8 million in cost for the upcoming fiscal year. And there were other opportunities that were reviewed with the committee, such as the CDS Prudent RX program, changes to gene therapy coverage, increasing copays for ER, outpatient surgery centers, that did not end up being approved, or the Prudent RX did, but there were other opportunities that were not approved. So I just wanted to provide that context. It was presented in a bundle of other opportunities and was actually not recommended by WTW at that time.
Thank you so much, Director. That helps answer the due diligence question that I had. I appreciate it.
Absolutely. Thank you.
Just to follow up to the Insurance Commissioner's question or comments, that those net savings include the increase that we would see through primary care expenditures.
That is correct.
Okay.
Yes.
All right. Thank you.
Do we have any other comments regarding the materials presented? Seeing none, I think Mr. Tashner wanted to make a motion.
and I appreciate everybody's comments. So I would like to move that we continue coverage of GLP-1 medications for weight loss for the commercial population, and effective July 1, 2026, implement a standalone copay of $132 per month, contingent upon the continued availability of the copay assistance program.
Second.
Motion made and seconded. Question on the motion. Bill Overly.
I just want some clarity. So if the copay assistance were to go away, it would result back to $32.
Yes, and actually, can I speak to my motion?
Sure.
So I think it was Yogi Berra that said deja vu all over again. And I feel like I'm sitting here today living that out, because once again, as the Lieutenant Governor pointed out, we place good faith reliance on guidance and advice and made decisions that we thought were good decisions that turned out to be bad decisions. And now we're left with trying to have to correct those. I didn't come to this recommendation and motion easily. I spent a lot of time thinking about other options. I reached out to the budget director and mentioned several of them. One of them, as you know, I brought up in the last meeting, was the whole idea of tiered copays. We're hearing today that that's impossible. I honestly don't agree with that characterization. I think for people outside the program, like my employees, we could be asked to give you certification of salary. And if we didn't provide it, we go to the highest level of copay. There are always ways to figure out how you can do something. You don't always have to say, we can't do it. Yesterday, I raised the possibility of a pause or a moratorium on future approvals for the next plan year. But my understanding is that CVS or Novo Nordisk would not look on that favorably, and it would negatively impact our rebates. So I think what we're left with is trying to figure out the best of a bad set of options. I landed here because after taking the time and looking at it and understanding the copay assistance, if we implement this recommendation, it will benefit the state. It will bring in the additional copay, but it'll be recovered through the copay assistance program. And I think that's incredibly important, because the risk here, I want to be clear, the risk in what was in the slide deck that didn't have my added language of contingent upon the continued availability of the copay assistance program is on the plan member. And I am not willing to make the plan member walk a tightrope without a safety net. So what that copay assistance contingency does is creates that safety net. And I hope that the spotter in this situation is SBO, which is going to make everybody aware that the copay, the safety net exists, so that we get maximum benefit. I have my own speculation that probably somewhere at the drug manufacturer, they know the certain percentage of people that take advantage of this. And I worry that if we exceed that, what could happen? We ask about the existence of the copay assistance program, could go away tomorrow. Stephanie reached out, they're not willing to guarantee it. So at this point, I have no trust that they're going to continue this. Trust is to be earned. It has not been earned in this situation. So I'm willing to take this leap of faith with the added assurance, with the safety net, and with the spotters, because I think it's the best option that's available to us to address the financial pressure on the budget, maintain the continued availability of the drugs to people who are in the program, and to not negatively impact them. And I want you to think about this. So it's going to be $120 a month more, or $100 a month more for 12 months, $1,200. If I'm making $100,000 a year, that's 1.2% of my salary. If I'm making $50,000 a year, that's 2.4. If I'm making $25,000 a year, and we have a lot of employees that do that, that's 4.8% of my salary prior to taxes. 5% of my salary goes to my pension contribution. So that's why I think a safety net is necessary to continue the availability and the affordability of these drugs. So I just wanted to explain my motion so other people understand what goes on up here, and what my thinking was. I'm happy to answer any questions, but I wanted people to have that context. So thank you for giving me the opportunity to put that out there.
Sure.
You answered my question. Thank you.
Bill Overly.
Just one question, I guess, to SBO. Are you prepared, assuming this motion passes, to have a robust program in place for outreach?
Yes, thank you, Mr. Oberly. This is Director Hardis. So we do have very robust communications, especially leading up to open enrollment. So for example, where this would be communicated and reflected, we would not be independently calling employees to make them aware of this. However, we did already confirm with CVS, who does have that information and does do that direct outreach, that they would be sending a letter to every single member who currently has a prescription for Wegovy to make them aware, one, of the change to copay, and two, of the Wegovy savings card and how to access that. In addition to that direct outreach from CVS, of course, we do our communications for open enrollment very robustly, including email communications and mailing communications on what's changing in the plan, which is where this would be reflected. Plan booklets, we have our Get the Facts on What's Happening document that goes out monthly, our benefits bulletins, and again, communications through US postal mail as well as email, really informing members on what is changing as they go into their benefit elections. So would it be direct, our office calling every single member to make them aware of this? No. But CVS would be individually outreaching to those members, and we would be doing very robust communications to the entire population on these as well as other plan design changes.
Follow up. You have input into what CVS communicates?
Yes. Yes, we do review and approve those letters. And if I may, just from an administrative perspective, often what happens with these savings cards, they may not go away entirely. However, they are often reduced. So I would just like clarity from Mr. Tashner on your motion. If the savings card is reduced, though not eliminated, say it goes from $100 to $50 effective January 1st, would this motion then drop the copay from $50, not completely reverting it to the $32 copay, but being in line with the change to the savings card?
That is the intent, so that the plan member is held harmless
Okay.
while the state's benefiting from the increase in the copay, because it's being recovered through the copay assistance program.
Thank you for that clarification.
Mr. Chairman?
Fair question.
Yeah, a question, I'm not sure, it's for Jeff, Stephanie. So if an employee is on some other GLP-1 drug, bunch of them, they just would pay the full copay?
If I can start and then you can clean up whatever mess I make. So what we're talking about here is for weight loss, not for any other condition. And in the weight loss area, it's my understanding where we're limited, well, I guess for the whole plan, we're limited to Wegovy now. But this is addressing weight loss only. It's this population of 6,000 that we have another population. I think the projection was that like 15% of these people may actually fall in that other population for diabetes and other conditions that qualify.
Okay.
My understanding is the copay assistance is available for everybody, I think, but we're addressing this population. Are you going to be raising the copay for the other population or just this population?
No, this is specifically for the weight
Yeah.
loss GLP-1
That's what I thought.
medications. And as far as savings cards for other drugs, I believe they are available. I do not know what they are off the top of my head. But my understanding, this motion is very specific to the weight loss GLP-1s covered under the plan. It would not include other indications such as Ozempic for type 2 diabetes. That is not under consideration for an increase.
Thank you.
Any other discussion on the motion? Call for a roll call?
Director Maxwell,
No.
Secretary Gordon,
No.
Lieutenant Governor Gay,
No.
Treasurer Davis,
No.
Commissioner Rivera.
Is it too late for a question? Is this motion basically option 2, or is it different from option 2?
It's option 2 with a copay of $132.
Yes.
Secretary Young, no. Deputy State Court Administrator Ashley Tucker.
No.
Jeff Kashner,
Yes.
Paul Bombach,
Yes.
Karen Peterson,
Yes.
Bill Overly,
Yes.
Having failed to receive the sufficient number of votes, motion declared defeated. Any other motions? Secretary Gordon.
I move that we adopt, I think it's option 2A, which he showed a list of options, implementing a standalone copay of $200 per 30-day supply for weight loss GLP-1 medications to be effective July 1st, 2026 for the non-Medicare population. In addition, my motion includes that SBO provide robust communication to plan members regarding the copay change and promote available cost-saving resources, including the Novo Nordic Wegovy Savings Card and the Healthcare FSA options to help members manage their out-of-pocket pharmacy cost.
I'll second the motion, but I'd like discussion on the motion, please.
So we have a motion and a second discussion on the motion. You want to go first, Lieutenant Governor, with your discussion? Yep. Okay. No.
Yes, please.
We have Secretary Young.
Okay.
Go ahead. Lieutenant Governor.
Okay, I'm so sorry. My it cut out for a minute. Thank you. I wanted to understand when we're talking about a copayment for a class of drug. We know that currently the only class available under the formulary is Wegovy, but does the decision today on the class extend to if other types of the drug, like if like the Lilly drug were to come back in, or is this just for Wegovy?
Do you want Director Hardis?
Thank you, Dr. Hardis. So this would be for the full class of weight loss GLP-1 medications, which at the current time is just Wegovy. However, in that scenario presented, say Zepbound were added to the formulary on July 1st or September 1st, whatever that would look like, yes, they would still be subject to that $200 copay unless the motion is made specific to Wegovy.
And can I ask, it would be for another drug in the formulary, it would be the 200 outside, unless there was a separate negotiation for a direct-to-consumer rebate similar to what is being offered for Wegovy. Is that correct?
That is correct. It would be the $200 copay would be the default.
And you have been unable to confirm that the $100 will maintain over the course of fiscal year 27, but you're hopeful that that will continue to be the case based on your conversations with our partners who are offering the Wegovy rebate.
That is correct. And I'm happy to give some more context to the discussion I had with Novo Nordisk. They made it very clear that they are not willing to enter into any agreement to guarantee the $100 savings card will continue through any given time. And they made it clear they have the ability to end the savings card at any given time with or without notice. Now, that being said, they have never done that previously. The savings card for Wegovy has actually been in place since Wegovy was approved, I believe back in 2021. And they do not foresee eliminating that savings card. Now, I will also say that discussion took place prior to Novo's most recent announcement where they are decreasing the acquisition cost of the drug from the $1,349 to $675 effective January 1st, 2027. So that may very well impact what the savings card would be for future years. Though they were very clear, they do not anticipate ending the savings card program, but again, it technically can be ended or modified at any time. And it isn't uncommon for drug manufacturers with a savings program to adjust the savings amount. So again, it could potentially through 2026 still maintain that $100 savings amount. And then in 2027, they may choose to reduce it to $50 or $75 or may potentially get rid of the program. But again, unfortunately, that is not something that they are willing to commit to the longevity and the associated savings. But we do not anticipate, strictly, quite frankly, from a business perspective, it would be very much against their own interests if they were to end the savings program.
I understand. And can we also confirm that, and thank you for putting the new pricing on the record here, because I know there's been conversation about different pricing, but can you also confirm that the pricing that's being quoted is, it's not like we're getting that pricing, we're still having to go through the PBM in order to understand what our gross and then rebate adjusted spend would be on the drug, is that correct?
That is correct, yes. So the announcement that Novo Nordisk had made about 2 weeks ago was that they, effective January 1st of 2027, would be reducing essentially the acquisition cost of the drug, which is $1,349 a dose, down to $675. However, we are looking at net costs, which includes the rebates. And CVS is still very much and will be over the next few months negotiating with Novo Nordisk on how that will impact rebates. Our preliminary understanding from information that WTW was able to obtain is that we do not expect this would impact the net cost. So essentially, we would expect some reduction in rebates as they are lowering the acquisition cost of that drug. So I would not put much stock in assuming that we're going to maintain the current percentage of rebates under the new acquisition cost of $675. And it'll take quite a bit of time in negotiations between the PBM and the drug manufacturer to agree on what those rebate terms are.
And then I think my final question is, this is, as we see on the screen, a fiscal year 27 conversation. And am I correct that as we observe changes in the market, and if we are to be, if we incur any changes in the rebates, or if our state employees and their families incur any changes in the rebates, that our next decision point would be around this time for fiscal year 28?
Thank you for that question. This is Stephanie again. The SCBC can make changes to the copay structure at any given time. So we always recommend that align with the start of the plan year, as that could go into a member's decision on what they're deducting for their FSA or what plan they're enrolling in. So we always recommend that it align with the start of the plan year, but there's no requirement that it do so. There have been instances where plan design changes have been implemented on September 1st or January 1st. So it's not a requirement, and the SCBC can certainly revisit at any time. But again, just based on the other decisions that members make when they're electing their benefits, we always recommend that it coincide with open enrollment so they can make a full scope decision when they're enrolling in their health plan. And again, for the FSA contributions as well, that's a large part of it.
So, Mr. Chair, just one additional comment, if you don't mind. So just in the interest of saving our friend and colleague, the Controller General, from having to jump in and explain, I assume that what you're explaining with mid-year transition would potentially could impact the budget and would have to be done in consultation with an understanding as to whether there could be movement there, if at all.
I can address that. Obviously, we set the rates based on a fiscal year or a plan year. If there were changes to be made, we'd have to look at what the financial impact would be on the plan. Obviously, we wouldn't want the plan to end in a negative. And so we would have to take that. But it wouldn't have to require action from the legislature because this is kind of a standalone fund.
Thank you.
I believe Secretary Young was next, and then we had Paul, and then so Secretary Young.
Sure, I can be brief. I think we all agree that we have only bad choices in front of us. We are making a really hard decision between increasing costs for the state and for all enrollees in the plan, and increasing costs for the users who are relying on this drug. I think we also all agree that it is not the fault of anyone on this committee, which has tried to be extremely creative in ways to reduce costs for the state. I think the blame for the difficult situation we are in lies very squarely with Novo Nordisk, who is behaving unreasonably. They are taking advantage of taxpayers and employers and employees across the country. They are taking advantage of the patients whom they purport to serve. And the pricing here has gotten egregious and is putting us in a really difficult situation. I'm glad that we are not talking about a motion to terminate coverage completely for these drugs. I am proud that we are trying to chart a path where we get to maintain coverage at some level, and so recognizing the incredibly difficult situation and the hard trade-offs that we are making, I will support this motion.
Thank you. Paul?
Yes, thank you. The question's for Director Hartos. I think I heard you say that the only GLP-1 covered by our plan is Wegovy, but on slide 5 of the previous deck, it noted that Ozempic and Rybelsus are indicated for diabetes, which Wegovy is not. Are we covering all three, or are we covering just Wegovy? And if it's all three, would all three be covered by this proposal, this motion?
Thank you, Mr. Bomback. This is Director Hartis. For the weight loss GLP-1 drug classification, Wegovy is part of that classification. Ozempic and Rybelsus are not FDA approved for weight loss. They are FDA approved to treat type 2 diabetes. So currently, under the weight loss GLP-1 classification, under our formulary that we have with CVS, Wegovy would be the only weight loss GLP-1 impacted as of today. So the Ozempic, Rybelsus, that is not a part of this conversation, as they are covered, but they are covered for indications of type 2 diabetes.
So this is just coverage for medication for weight loss. The same drug, if it was used for diabetes, would not be covered by this new standalone copay. Is that correct?
So if someone has a diagnosis of type 2 diabetes and they are using Wegovy, they would be subject to the $200 copay. They should be on Ozempic if they have a diagnosis of type 2 diabetes, their provider would have prescribed them Ozempic and not Wegovy.
Sorry, and
Which are chemically identical. That is correct. However, the FDA approvals are different for the drugs. It is not by diagnosis. So this copay will not be assessed by diagnosis code or by clinical conditions. It will be by the drug itself that is being approved. So if someone has a prescription for Wegovy, they would be subject to the $200 copay regardless of what clinical conditions they have.
And they would also be subject to that copay for Ozempic or for Rybelsus?
No.
So no or
Ozempic
yes?
and Rybelsus are only covered for type 2 diabetes. And
So
let me change that. They are covered for other indications in accordance with type 2 diabetes. Weight loss is not one of them.
Okay, and if somebody gets Wegovy for diabetes, sorry, I know you said it, say it again, they are affected by this or not?
So if someone has a diagnosis of type 2 diabetes and they have a prescription for Wegovy, they can request a prescription for Ozempic through their provider and would be subject to the $32 copay.
Okay, so Wegovy only gets affected by this, even though the formulation is identical to Ozempic?
That is correct, yes.
Okay, seems a little. Just seems odd to me, but okay.
Bill, you were next. I'm fine. Any other comments? Jeff Dashner.
Yeah, folks know I like that and I like numbers, and I just want to be clear. This proposal would raise the annual copay on the plan member by $2,016. Only if copay assistance is available does that get reduced to $816. And I think when we look at our merit employees based on data that was given to me, over half of them earn $50,000 a year or less. So I really struggle with them being the only ones, quite frankly, who are bearing the cost of this action. We're not lowering the price. The state's not paying any more. In fact, the state's benefiting dollar for dollar from the copay. Let's be clear, this is being done on the back of these 6,000 members who had nothing to do with the decision that was made based on bad information, bad guidance, have in good faith gotten the prescriptions that have met the medical prior authorization. You all read those stories, they're life-changing. Several of them, back surgery, heart surgery, no longer necessary. Think about the increased productivity, probably the downturn in absenteeism, but yet that's who is gonna pay. And that is why I will not be voting for this proposal.
Mr. Chairman?
Karen Peterson.
Yeah, I follow up with what Jeff said. You know, studies have shown that people who discontinue GLP-1 drugs, which a lot of those people at the bottom end of the pay scale will be forced to just stop taking it. They will return to their pre-treatment weight within 2 years. So all that money's been wasted. All the benefits for that will be for naught. The weight comes back at about 1.8 pounds a month, along with all of the risk factors like blood pressure, cholesterol levels, and so forth. And they will return to all their pre-treatment levels within a year and a half. If we discontinue coverage, well, not discontinue it, but make it unavailable to people making $25,000, $30,000 a year. I mean, Jeff just talked about the cost of it. Then all the benefits of having taken those drugs will be lost. They're going to revert right back to where they were when they started. And only the people at the higher end of the pay scale will be able to afford these drugs. I think it's just a huge mistake to, I'd hope that we could have, a sliding scale or something to make this available to everybody. But obviously it's not going to be available to everybody because they simply can't afford it. So I will also be voting against this proposal.
Hold on. Bill Oberly.
Yeah, over the course of my service on this committee, I kind of come full circle on the GLP-1 issue. And I think a lot of my concern over GLP-1 usage was vested in a lot of anger around the misinformation that the SCDC was given in terms of the cost of evidence. But the bottom line for me is the long-term benefit use of this drug all only should save the state money and certainly improve the welfare of those taking the drug. I think this is one of the times that policy has got to drive the budget as opposed to the budget driving policy. So I intend not to support this too much.
Senator Davis.
I just wanted to say that I do appreciate how challenging this decision is overall, and that again, I think it was said best by Secretary Young that we're sort of evaluating bad options all around. I think we all sort of agree that it would be ideal to be able to offer these medications to a population that is in need at no cost. I just wanted to confirm that from a maintenance perspective, we still have available alternatives, alternative coverage for weight loss maintenance in the plan itself. And I don't know if Director Hartos can confirm that.
Yes, thank you, Treasurer Davis. I can confirm that there are other weight loss medications that are covered under the GHIP that are not GLP-1s. So those would be, there's smaller pill ones such as Contrave, Orlistat, very underutilized. They've been on the market for a very, very long time. that would not be subject to this. This decision is specific to the GLP-1 medication copay, though there are other medications that exist for weight loss that are not GLP-1s, and I mean, quite frankly, not as effective as a GLP-1, but that are FDA approved for the treatment of weight loss. And I'm not sure if Brian Holleran, I believe, is on the phone. He is our pharmacist. Kristen McKee from WTW, who is our pharmacy expert. I'm not sure if there's anything additional you can speak to for that.
So not hearing anything from her, I just wanted to add, I think we also have non-medication options as well. And I think that when we talk about maintenance of weight loss, there are multiple options before every employee that has taken advantage of the GLP-1s.
Yes, thank you, Treasurer Davis. That is correct. We offer multiple diabetes prevention programs. For Highmark members, there is the Noom Diabetes Prevention Program. For Aetna members, there is Solera. And actually for all members in the non-Medicare population, we also offer the YMCA Diabetes Prevention Program, which is completely free for members and actually comes with 4 free months of a family membership to the YMCA as well. And we're also currently, which we're hoping to hear from today, it's later on the agenda, having the 4th diabetes prevention program through Reciprocity, which is actually an incentive-based diabetes prevention programs where members are being paid cash to attend YMCA DPP sessions. So there are non-medical opportunities or non-medication opportunities as well for diabetes prevention and for weight management.
Okay, sounds like a very, very robust alternative plan. So thank you.
Lieutenant Governor.
Thank you, Mr. Chair. I just wanted to take a pause for a moment and note that though the last vote and likely the next vote will look like this committee is diverging on 2 different paths, I actually think that we're quite aligned on what matters most for the employees who we are serving here. This committee has not considered today whether to pull these drugs from the formulary in the way that other states and other large plans have in recent times. And I think that is a strong reflection of this committee's shared understanding based on data and our own personal experience with Delawareans and their families, that these drugs are having an incredibly positive impact on the health and well-being of the people around us. I think it's important to note that there's about an $816 difference between the last vote and this vote, and that is real money, and that is a real change. But I think we also need to remember that as we consider everything on this committee, that we have a responsibility to many different types of members. We have a responsibility to members who are facing other incredible health challenges that are also costly. And I hope that we take just as much time to consider considerations like special drugs for cancer treatments and the like. So I know that this has been a difficult conversation. I agree that we do not have good options in front of us, but I would also point out, as I think I did earlier, that I think that there is an opportunity for us to have good options in front of us moving forward. And I very much anticipate and expect this committee to consider those options and to pursue those options, including anything from tiering costs to ensuring that we are providing greater coverage for individuals who are taking part in certain programs to amplify their health and well-being. There are so many innovative approaches. We have gotten to this position today where we don't have the opportunity to do that and also caretake the financial well-being of our plan. I'm disappointed in that, but I'm going to make what I think is the best decision in front of me that I can possibly make. And then I will move forward with the understanding that the cost is still too high and that we need to do something to ensure that medications that change lives are getting to the people that need them.
Thank you.
Mr. Chairman?
I think.
So I just want to be clear so that we don't later on in the conversation we have the answer. But if Wegovy goes, if we're just talking about the injectables. So if Wegovy goes to like a pill, for example, that's significantly less expensive, would that be factored in and they have one more that?
Great question, Commissioner. This is for both the Wegovy pill and the injectable. The pill was approved and went to market in January.
Forgive me, but are the pills significantly less expensive?
Not what's being charged to the state, no. At the direct to consumer rate, yes, at the cash price, yes, they are. At the rate that is contracted under the state, they are the same as the injectable.
Yeah. But the other comment is to Senator Peterson's point. This is why an entity like Flight Health, and I have no skin in the game with them, but I know what they do is they sit down with our GIP members, and they help them determine what's the best plan for them. Some are on weight loss medications you shouldn't be. Some don't have the BMI in place, so they should be maybe another track. And so by having that TPA manage this for the our coworkers is a big plus, and will be a big statement to the state.
Karen Peterson.
Yeah, thank you, Mr. Chairman. So I just want to be sure I understand this standalone copay. 120, 132, 200, what? If there's only one pill available, Wegovy, or one shot available, what are the three different copays?
So this is Director Hardos. So the three different copay options being presented today, it's regardless of the dosage of the medication. So whether someone is getting the highest dose of the injectable or of the Wegovy, or they are on the lowest dose of the pill, which is typically only for the first 2 to 4 weeks. You typically build up the dose over time, and then you're at what's called a maintenance dose, which is that higher dose. The copay would be the same regardless of the dosage and regardless of whether it's injectable or a pill.
So you work your way up to $200 a month?
No, ma'am. The motion that's currently on the table is the $200 copay per 30-day supply. That is regardless of dose and administrative form. So whether it's an injectable or a pill.
So it's 200 for everybody.
Correct.
Thank you.
Any other comments? Seeing none, roll call.
Director Maxwell,
Yes.
Secretary Gordon,
Yes.
Lieutenant Governor Gay,
Yes.
Treasurer Davis,
Yes.
Commissioner Navarro,
Yes.
Secretary Young,
Yes.
Deputy State Court Administrator Ashley Tucker,
Yes.
Jeff Tajner,
No.
Paul Baumbach,
No.
Karen Peterson,
No.
Bill Oberly,
Have received a sufficient number of votes, motion carried. Moving on to agenda item number 8C, approval of health premium rates.
So Director Maxwell, the slide that's up on the screen right now are the rates that are based on the motion that just passed, which would result in a 2.2% rate increase for FY27, effective 7/1/26 for non-Medicare and 1/1/27 for Medicare participants. The column over to the set of columns to the right, dollar change in employee and pensioner contributions show the monthly and annual increase in participant contributions under that same scenario, which range you can see from a low of 96 cents per month for a person in employee-only coverage under First State Basic, ranging up to a high of $9.44 for an individual electing family coverage under the comprehensive PPO. And for Medicare participants, the increase would be 40 cents per month for those with Medicare coverage without prescription drug coverage, and 70 cents per month for Medicare participants with both Medicare and prescription drug coverage under the GHIP.
Entertain a motion for a Secretary Gordon.
I move that we approve the fiscal year 27 health plan rates that are presented on this slide 9, implementing a 2.2% health plan premium increase for the non-Medicare health plans effective July 1st, 2026, and the Medicare supplement plan effective January 1, 2027.
I have a motion. Do I have a second?
Second.
Second by Secretary Young. Any discussion on the motion? Bill Oberly.
Yeah, let me come back to the age-old argument about increase in the Medicare side of the equation. Again, I mean, it's been firmly established that the surplus offsets and helps to fund the active and pre-Medicare retiring population. So I'd like to understand rationale behind increasing the Medicare population given that scenario.
So, to that point, you know, if you look at the contributions to that plan, I think the state, I don't know, Brian, I'm gonna pull that up. Contributions on the Medicare plan.
The actual dollar amounts that
Yeah.
participants pay, that's shown here at the
No,
bottom.
I think it's on slide 8, or I'm sorry, 6 of the presentation that is in our packet. I think it's the financial
No.
fund report, financial update. So I'll direct everybody's attention to the blue box, which is the actual, under the middle there, pensioners. And it's the state share of Medicare. The state's contributing $197.1 million for the coverage of that. And the pensioner share of Medicare is 10.4. So if you do the percentages, and when you say, you know, the surplus in the plan, it's really the state surplus of the plan, right? Well, to do as it should, right? To cover healthcare costs. And this is considered a pool, and it's been operated as a pool since the dawn of age. And Mr. Tashner is shaking his head because we've had this conversation that this has been treated like a pool. And if we're going to talk about pensioners, we got to talk about the pre-65 pensioners as well, because they're actually operating at a negative.
No, I understand that. And many of us have been arguing that we ought to have that conversation about looking at all three groups. My point is, the data does not include what a pensioner pays to Medicare for Parts A and B. And it does not take into consideration that it generates a surplus.
The surplus is the state's money. We could put less money into it. Right?
Mr. Chairman,
Yeah.
not necessarily. There are thousands of retirees who pay the full freight.
Who?
Medicare people who didn't have enough years service, retired long time.
But sometimes it's few. If you do the math, do the math. 194. So let's get the facts right.
Well, yeah, because last year it was in the thousands. So I don't know how it became 194.
This is
That
Director
paid all or part, the 75%, 50%, 25%, depending on length of service. You're saying there's only 194 people?
So this is Director Hardis. I'm happy to read through that. So last year was about 160 people paying the full premium.
But
This
how about
year
the
is
75, 50,
194.
and 25?
Yes, so paying, let's see. So there are 28,127 Medicare retirees who are currently enrolled in the GHIP. So of that, 57% pay $0 for their health plan premium under the state. 30% pay 5% of their health plan premium. So to kind of re-go over that total, 25,423 Medicare retirees. Of that 28,000, so that's 90.4%, pay 0 to 5% for their benefits. So if you're looking at, let's see, 5.9% are paying 25%, so that's 1,666
So as I
members.
said, thousands are paying all or some.
So yes,
Okay.
25% of their premium. So that is between.
all or some.
Nah, I think you mostly said all.
No, it didn't. Did not say all.
Okay.
I said there are thousands of people who are paying all or some of that full amount. They're contributing, that's their money, not the state's surplus. Now, when we talked about this last year, you said, it's in the minutes from that meeting from March 25th last year, you know, we need to talk about it. We can talk about this in the future. Well, this is the future. And Medicare retirees are still being charged, well, 29.6 million more than it costs the state to pay for their benefits. Now, I understand part of that can go to the pre-Medicare retirees, all that, they're also retirees. But even so, that still leaves a surplus of like $12 million. Now, y'all brought in the guy from pensions last year who said, oh, this is all legal and blah, blah, blah. And you know, it might be legal under the law, but the question is it fair? The retirees, when you charge state employees 13% of what the state pays for their coverage, okay, 13%. Medicare retirees pay 113% of what their coverage costs. So you got 13%. I see you looking at me. If you take their cost versus what the state pays, the total cost of their insurance, take the comprehensive plan, the PPO, all right, and divide that by what their premium. Their premium's $165 for the comprehensive PPO. Medicare retirees are paying $823 a month. That's the state's charge, the state premium of $638, plus what was taken out of our Social Security for Part D insurance, which is $165. So we're paying $800 stuff. They're paying $165, right? I mean, it is so unfair that the old folks are footing the bill for the young folks who, by the way, got a 31% increase under Governor Carney. We got like 2% under Governor Carney. So the people who are making the money, getting the pay increases, are the ones that are benefiting from what we're paying. And that's those thousands of people who pay either all or part of the full premium. Now, if I were back to put my old Department of Labor hat on, I would say this whole arrangement smells a lot like age discrimination. When you charge the old people more than it costs the state, and you charge the young people way less, 13% of what it costs the state, that on the face of it is so unfair and so wrong. And I just, I know you're tired of hearing me talk about it, but there are people out there who have had to leave our program because they couldn't afford the $823 a month. Because it was a husband and wife. So that was $1,650 a month. But it's okay that state employees could walk away at $165 a month. There is just something wrong. And I know you like to keep us all lumped together. It's all so nice and neat that we're all just lumped together. But every time we increase, it's easier just to raise everybody's premiums the same rate. Well, a 4.2% increase on $638 is a hell of a lot more money than 4.2% on $165. Once again, Medicare retirees are getting screwed, and every year it gets compounded. Every time we increase that 27% we had like 2 years ago, the retirees really got screwed on that one, and we continue to get screwed every time this gets compounded. I don't know why it's so sacred that everybody stay in the same big group together. We'd be happy to be out of that group because we're paying their way to a great extent. So I know I'm spitting into the wind, but
I'd be happy to just give you a voucher and you can go procure it in the market yourself if you can come up with a number.
Why overcharge?
I'll overcharge you. Give me an alternative. If we're getting overcharged, tell me what you need. I'll give it to you, and then you can go your separate way.
Roll that number back 13.6%.
And I'll take it and give it to you, and then you'll be separated from the plan. Is that what you want?
You don't have to throw us out to be fair to us.
No, I'm just saying I don't want to rip you off.
Well, then don't.
I'm just saying that's the alternative.
Roll the premiums
That's
back
the alternative.
to what it actually costs the state to pay for our
Tell me what it is.
Well, tell you what that number is?
Yeah.
Well, it's 13, it's 638.
Can you buy that on the,
Minus-
can you buy it on the
That's not the
marketplace?
issue. Don't do this
Okay.
around here. I could buy a Plan F on the open market for $152, which I would have bought had we been thrown into Medicare Advantage. Already had the policy, $152 a month. I have no idea why the state charges $680, whatever, dollars a month. But this has been so wrong that premiums that are attributed to the Medicare retirees are wrong. We called them back in 2022. They were faux premiums. They were faux premiums then, and they're faux premiums now. But you continue to take advantage of the old folks by making them subsidize the young folks. And that's just wrong.
Other comments?
If I can just come back, I think, and Jeff and I have talked about this for years, about taking a look at the three groups and trying to better understand how we can equitably distribute what they're costing the state. The 365s are the real problem in terms of cost. They're the high cost population. So we need to take a look at how we assess these premiums in a holistic way. And I think if you do that, then you'll find that increasing premiums on the Medicare retirees, if we were at that point, would be zero right now. The 365s would be significantly higher. That was my point.
Any other comments? Lieutenant Governor.
Great, thank you. So much. I just want to make sure, again, the slide I see in front of me is employee contributions. The motion was made related to the 2.2%. We're having a conversation about the retirees.
They're on here as well. It's
Okay.
the
Can you
column
point?
one there. 2.2% increase as well.
Thank you. So just flagging for everyone, the pink is employee. We're actually voting on employee and retiree contributions.
That's correct.
And great, thank you. And again, just to go back to my prior comment, this is a decrease in percentage increase than what we previously discussed as a committee at the 4.2 level. Is that correct?
That is correct.
And are you attributing the 2% decrease in the increase solely to the decision previously made on GLP-1 coverage, or are there other considerations and decisions that have been made that contribute to the 2% decrease in the increase?
The only other plan design change that we made was referencing Lantern changes that we made at the last meeting, but
Okay.
the decrease from 4.2 is being driven by the change in copay structure.
So both employees and retirees, if this passes, will see less of an increase than was contemplated at this time last year.
That is correct.
Okay. And will this committee again revisit that 3 to 4 year outlook if this passes, since that would have been a change to what we considered a year ago?
Yes.
Thank you.
Any other comments?
Just want to follow up on what the Lieutenant Governor just asked. Brian, can you tell us what the reduction is in the annual cost from 4.2 to 2.2 for an employee on the most costly plan, which is the comprehensive PPO family plan?
You're muted, Brian.
Sorry about that. Jeff, are you asking what the contribution increase would have been at 4.2% compared to the 2.2?
I know it currently is annually 113.28.
Yep.
I'm assuming it would have been a little more than double that.
Yeah, so what would have been option 5? At the 4.2%, it would have been 216. So, right, relatively double.
So about $140 or less than 1 month of the increase that the previous vote placed on them.
I didn't follow you there.
So the previous vote increased from $32 to $200 a month copay, which $168 a month. Here, the annual savings is going to be less than that $168, which is a 1 month increase. I just want to put it in context because we talked about they'll see decreased premiums, but the decreased premiums on an annual basis will be less than 1 month of the increase. Just want to put it there for contextual purposes.
For the GLP-1.
Yes.
Just for the people who are taking the GLP-1.
And I just point of clarification, you're excluding the $100 that they would get, right?
Well, I'm not counting on the $100 because we are taking a leap of faith and placing trust in people who I frankly, based on their track record, have not earned our trust. God, I hope that what you all predicated your vote on stays true. But if it doesn't, and I'm one of those people who is now bearing that additional $168 a month, I know whose phone I'm ringing or emails box I'm filling or text I'm sending to, because that's the concern I've tried to articulate. Maybe haven't done it very well, but I worry that the only population that is at risk for additional cost is that group. And let me put it another way. Even if that's in place, they are now paying $816 or 800 and some dollars a month, a year more, which far outweighs what they're getting back on an annual basis. I just want to make sure we have the full picture here of what we're doing, especially to our lower paid employees.
Mr. Chairman, may I add that we're charging the Medicare retirees for a drug that they're not even entitled to get, along with some other programs that they're not entitled to, but yet they too are going to get the increase.
Yes, sir.
Colleen?
I just wanted to clarify where Jeff Tashner's describing the population that is receiving GLP-1s for weight loss, right? Not the entire population receiving GLP-1.
Even at the copay assistance, the vote taken earlier is increasing their annual cost by $816. The reduction in premium is going to be roughly $140, $130. So my point is that they're still bearing the cost of this. And again, we've done nothing to reduce price. Novo Nordisk continues to get what they get. I said enough.
Okay. I just, I was just curious. I think that we've also had very robust discussion around coverage. I'm just thinking historically where we did some carve out of a population related to in vitro fertilization. And we really had a lot of discussion and concern over how it was going to impact that population. I think it's a similar dynamic here. And I just want to point out that there are several populations that we absolutely need to be considering in how we constructively put together a plan that's going to do our best to meet their needs, their individual needs, and the overall population in Delaware's needs.
Any other comments? Seeing none, roll call.
Director Maxwell,
Yes.
Secretary Gordon,
Yes.
Lieutenant Governor Gay,
Yes.
Treasurer Davis,
Yes.
Yes.
Secretary Young. Yes. Deputy State Court Administrator Ashley Tucker,
Yes.
Jeff Kashner,
To be recorded as not voting.
Paul Bombach,
No.
Karen Peterson,
No.
Bill Overly.
I haven't received a sufficient number of votes, the motion carries. Up to number 9, approval of the pharmacy benefit management request for proposal.
Yes, thank you, Director Maxwell. Michelle, are you able to just share just the front page of the RFP? All right, so good morning, committee members. So this is Director Hardis. So today we're wrapping up discussions on the 2026 PBM RFP and requesting your approval of posting of the document to the GSS website for procurement for a contract effective date of July 1st, 2027 for the commercial plan and January 1st, 2028 for the employer group waiver plan. The final draft of this RFP was shared with you all and posted publicly on Monday, March 9th. There is only one slight difference to this version and the version that was shared last month on February 16th, and that is that the RFP schedule and timeline has changed slightly. So as you all know, our last meeting on February 23rd was canceled due to weather, and GSS requires 10 days prior to posting of the final copy of the RFP. So in order to ensure we were in compliance with GSS timelines, we did just have to delay the posting date from March 11th to now March 25th. However, the proposal deadline is still the same at April 27th. No other content has been changed in this RFP, and no additional feedback has been received by the SBO from committee members. Are there any questions or discussion to be had on this RFP or any requests to modify or review prior to approving?
Stephanie, I see in the follow-up questions and answers. First, we're down on page 6. Saying the requirements that it match, the RFP match what was issued in 2023 relative to the language that duplicate current supplemental plan.
This is referencing the PBM RFP, not the medical TPA. See, that's the next thing. Yeah. This is just for the PBM RFP.
Got the TP.
Yeah. There's no slide deck for the PBM RFP because it's just approving the actual RFP itself, and there were no changes, so there was no new items.
I apologize.
Yeah.
I would make that motion.
Is there a second?
Second.
Motion has been made and seconded. Any discussion on the motion? Bill Overly.
Discussion going back earlier to my earlier comments about perhaps considering a separate RFP for GLP-1s. Is that lost in the ether, or is that something that we can still pursue?
This is Director Hardis. So the language in this RFP allows for a separate procurement of GLP-1s.
I know it allows for RBAC.
Yes.
What I was referencing earlier was a separate RFP for PBM to supply GLP-1s. In line, I think, with the commissioner's thinking about a TPA, or excuse me, a PBM that could oversee GLP-1 distribution.
So for clarity, this RFP that is being reviewed and approved today specifically for standard pharmacy benefit manager services for commercial and AGWIP, there is included in that RFP that the PBM must agree to allow the SCBC to carve out for those medications such as GLP-1s, specialty drugs. It's not even actually just limited to GLP-1s. We made the language specific to, if there's a new class of medications that comes out in the next year or two that you're also interested in carving out of the plan. That ability is included in this RFP. However, we are not voting to approve a separate RFP to procure for that service.
No, I understand that. I just want to make sure that this doesn't get lost moving forward, that we can continue the discussion about the carve-out of a separate PBM to administer GLP-1.
Yes, this RFP does not limit that. That conversation can definitely continue. it wouldn't necessarily be a separate PBM. It would be likely through a TPA or through some form of direct contracting. But the decision to approve this RFP today does not look at that as an option for the future.
Any other questions? Ask for a roll call?
Director Maxwell,
Yes.
Secretary Gordon,
Yes.
Lieutenant Governor Gay,
Yes.
Treasurer Davis,
Yes.
Commissioner Navarro,
Yes.
Secretary Young, yes. Deputy State Court Administrator Ashley Tucker,
Yes.
Jeff Kashner,
Yes.
Paul Bumba,
Yes.
Karen Peterson,
Yes.
Bill Oberly.
Yes.
Agenda item number 10, medical third-party administrator, TPA services request for proposals.
Good afternoon, everyone. Michelle Gast again from WTW. Moving into our agenda for the medical TPA RFP. So the goal of this presentation is to provide some context on today's discussion, the follow-ups from the February 13th SCBC discussion, and then we have the existing material that had been slightly updated due to some feedback from SCBC members from the prior discussions. So the context for today's discussion, so during the November and December SCBC meetings, WTW presented the SCBC with the medical TPA RFP scope of services, as well as the overview of the RFP. The SCBC was then providing feedback over to WTW and the SBO on what they would like to be incorporated if they had not seen it yet in the scope of services. During the February 13th meeting, WTW and the SBO provided suggestions on what to consider for the minimum requirements, the questionnaire, and the scoring criteria for the medical TPA RFP for the SCBC's review and input. At that point in time, the SCBC provided input, questions, and we took those away and provided updated materials for today's discussion. During today's meeting, we will also review the answers to the Q&A. There were a few questions that we'll review quickly following these slides. And then following today, we are actively finishing up the draft of the medical TPA RFP, which has not been shared with the SCBC yet. So the full RFP document of the medical TPA RFP will be shared with the SCBC for your review prior to the March 23rd SCBC discussion. So the next few slides are just going to very quickly go through the follow-up questions that were from the February 13th meeting. So this material was provided to the SCBC in advance of the February 23rd meeting, which was then shifted to today. So this material was slightly updated due to some feedback that was received as well from the SCBC during that time. But just highlighting the two main questions that came up during the prior meeting, several SCBC members and public comment was raised around ensuring that all references to the Medicare supplement plan clearly reflect that it is to be duplicated using the wording from the 2023 RFP throughout the RFP for the medical TPA RFP. So that feedback was taken into consideration, and when you guys see the full document, you'll be able to clearly see we've reflected all of that in the RFP document for your review. Yes, which you haven't received yet. So the medical TPA RFP has that wording, including that it should be duplicated from the 2023. The next set of questions was around a retroactive termination. So an SCBC member during the last discussion asked for specific examples. So those were provided in this document. There's 4 different examples. Due to timing, I'm not going to go through each one individually, but if there's any questions on this, I'm happy to talk through them. And then just to make sure the full SCBC is aware, during the delivery of the materials for the February 23rd meeting that was shifted to today, there were a few questions from an SCBC member around the right-hand column here for the WTW recommendation, primarily just making sure where we highlighted things that were being added to the questionnaire, making sure we consistently stated that they would also impact the scoring. And then a few items, it was asked how we would address them in the questionnaire. So once the specific topics around care management was the one highlighted, as well as the ambulance coverage and also the rebates on drugs. just having clarity on the wording of those questions. Those will be included in the RFP draft that is delivered to the SEBC in the coming week or so, in advance of the March 23rd SEBC meeting, where additional questions could be raised on that wording.
Mr. Chairman?
Karen Pearson.
A question, on page 11, the feedback from the SCBC, the last entry, medical TPA, quote, high deductible, high health plan with health savings account. Did we ever discuss that? Did the SCBC ever discuss adding that option?
Yes, this has been discussed in the scope of services as well during the RFP overview and review, and was considered for this RFP.
And we added it as a requirement, as a.
It's a part of the questionnaire,
And it'll be.
and they can include it. They do not have to bid on it. They could only bid on the other plan options, but it is an option for vendors to bid on the FSA. I mean, sorry, the HSA
But
specifically.
the proposal review committee can also not accept, I mean, we received a letter from one person whose daughter is in this plan, this kind of a plan, not with the, obviously not with the state, but said that she has never, ever reached her. And it's, never even got close to getting reimbursed anything from the state. And he describes it as the Medicare Advantage plan for active state employees that her plan has never paid a claim, ever. She's never. I mean, this was from Bob Clark, and I think he sent it to everybody back in February 1st. And he said, unfortunately, the WTW and SBO are pushing a new benefits side cost control option in the upcoming medical RFP, the high deductible healthcare plan with health savings account. He said these plans are the Medicare Advantage equivalent for active state employees under the guise of turning employees into better healthcare consumers. In reality, they are worthless, catastrophic plans where the employee is virtually self-employed. Everything's been out of pocket.
All right, just point of order, that's a public comment, it's available to all members.
No,
I'm
wait,
not gonna
wait.
read other people's.
No, it wasn't a public comment. It was an email.
Okay.
Just sent to various members of the committee.
All right.
I would say I understand the feedback, but what has been considered in the RFP today is what has been discussed with the SEBC to date. So if that's something that needs to be reconsidered and discussed amongst the SEBC, I think that's okay, but it is currently included in the RFP based on discussions and requests from the SEBC as well.
And I remember being mentioned. I never remember it being discussed. That was my point.
It was raised in the scope of services and the RFP objectives discussion.
Go over it.
And perhaps a little counterpoint here. When I was in the private sector, I had an HSA and found it didn't work well for me at the time. And it may appeal to a certain number of people in state government. So I don't see any need to rule consideration out of an HSA, even though there may be a limited number of people that may want to avail themselves of it.
Yeah, it's not that having it means that everyone has to have it. You will still have your options that people can choose from.
Correct.
So again, this is the overview and updated minimum requirements, recommendations, questionnaire updates, and then there was no feedback on the scoring criteria to update. And for the next discussion, you will have the full RFP for review and any feedback from the SEBC that can be considered before it is finalized and approved. Sure.
Hello, Mr. Chairman. Bill Overly. And when can we expect to receive that?
So we're finalizing it this week, and as soon as it is finalized between WTW and the SBO, it will be sent to the SEBC. So you should have plenty of time in advance of the next
Will
meeting.
the feedback and inclusions be separate and apart from the boilerplate, or are we going to have to go through 181 pages?
I'm happy to help point, I think he's saying like specific items they want to focus on, like the Medicare supplement. We can refer you to pages. Yeah.
Extremely helpful.
Yeah.
Okay.
Any other discussion on item number 10, medical third-party administrator services request? Seeing none. Moving forward to item number 11, Therapay Diabetes Prevention Program Pilot. That is update.
Hi, good afternoon. My name is Aviva Ariel Donges. I am product manager and licensed clinical health psychologist. I'm going to provide the month 6 progress report to the SEBC on the Therapy Rewards pilot program that we have been doing for encouraging participation in the diabetes prevention program. Given the timing, I'll move quickly through this as it's just a progress update. There's no decisions needed regarding the program. If you can move to the next slide. You last heard from us back in November of 2024. Since then, the Therapy Rewards platform has moved ownership. So you may hear Reciprocity Health or Clutch Health both refer to the same project. We had been approved for 100 employees to enroll in the Therapy pilot program. The eligibility is provided by Highmark Blue Cross Blue Shield of Delaware, and funding for the pilot was through the established Highmark communications budget. And the goal was over the 12 months of DPP participation to increase enrollment and engagement. Move to the next slide, please. Just a quick overview about what Therapy Rewards is for those of you who may not be as familiar. Therapy is essentially a digital journey that is aiming at engaging people in whatever health behaviors their providers or payers would like to see them engage in. So we tailor the program, the app experience, which is available for web-based apps and on the phone, to show people exactly step-by-step what we want them to do. So in the case of the diabetes prevention program, it was completing an initial survey about their interest in the program, attending classes, and most recently completing a mid-program survey. Folks who sign up with Therapy Rewards get access to the app as well as a reloadable debit card so that the rewards are available to them to use just like they would any other sort of debit card. Really sort of leveraging those behavioral economics principles that we know work in terms of reinforcing positive behaviors. And then we report back to the state on how the outcomes are going. Next slide, please. This was the original pilot program that was approved, and this is what we're working with right now, where up to $275 in rewards would be offered for engagement in the 12-month DPP program. We anticipated that adherence would be high, but most likely folks would earn about $200 in total, and that was how we fit the budget. Next slide. So just to give you a high-level overview, we opened enrollment for the DPP pilot program in July, and within 7 days, we met the 100-person cap, and we initiated enrollment through the YMCA into the DPP, but because the YMCA only offers classes at certain times, it's taken folks a couple of months to start the 12-month program. So it took until the end of 2025 for those who were enrolling to actually start. And we're reporting now on being about halfway through, and we're anticipating our 12-month report, our final report to the SEBC will be this December. Next slide. And you can keep going. Just to give you a high-level overview about how enrollment went, as I said, we've reached the 100 member cap. And then in terms of folks who actually registered with the YMCA to start the DPP, that was 31 of the 100. And then 23 of those started attending DPP classes. If you'll continue on to the next slide, what I want to highlight is the change as seen with Therapy versus before Therapy, when the DPP was offered to this population without the app experience and without the rewards. And what we see is across the board huge increases. So in terms of registrations, in a typical 3-month period before Therapy, we would see about 7 employees registering with the YMCA. We saw 31 employees through the Therapy program. That's a 4.5 times increase. Next slide will show you about class initiation. So we saw almost a 4x increase in folks who went from signing up with the YMCA to actually starting classes. And then really the most important thing that we're looking at here is adherence over time. So we see about a 3x increase in adherence over the first 2 months of DPP classes with the TheraPay program. And then on the next slide, we'll see the ongoing class adherence. So at 4 months out of the 12-month program, we're still seeing huge increases in adherence. So a 7.5 times increase compared to the baseline. For the sake of the timing, I won't dive too much into the rest of the information that is available to you, but what we'll see is that a huge percentage of the participants have lost weight. We're seeing really excellent class attendance, and the rewards paid to date is on par with what we expected. And the next few slides go over essentially all of the positive feedback that we've heard from the participants of the program. So big changes in health behaviors and engagement with the program. I'll move on to just the lessons learned thus far. And in the addendum, you'll see details on the initial program survey and the mid-program survey, what we are hearing from the participants. But essentially, we saw that interest was extremely high. There were 70 additional employees who requested to be on a wait list for future TheraPay programs. We've seen a really positive impact on enrollment and engagement. Satisfaction is overwhelmingly positive. I think one of the lessons learned in terms of improvement for the future is that because of that 100-person pilot program cap, we saw that we reached capacity within 7 days, but a large portion of that population didn't actually start the DPP. As a former DPP coach myself, I think there's a lot of pressure to enroll quickly, but maybe it didn't give folks enough time to really think about whether they want to commit to a year-long program. So that's something to consider for the future. And then finally, the feedback that we hear in terms of areas for improving the program experience are really focused on faster time to incentives being paid out on the debit card. Right now, we're limited by the data sharing schedule from the YMCA, but in the future, if this program were to expand, on the TheraPay side, there are no limitations to doing faster data sharing or even integrations directly with the YMCA, so that as soon as a member attended a class, they could be paid out the same day. So I'll stop there and happy to answer any questions or happy to take that offline if folks have comments or questions about the program. Well, thank you very much for this opportunity, and we will be back in another few months to give you another update on how the program is going.
Does anybody have any questions on the TheraPay Diabetes Prevention Program pilot? Seeing none, on to financials.
Thank you, Director Maxwell. I'll go quick. I know we're pretty far over time, so I'll go through the results and then let committee members ask questions that they have. So for the month of January, in total, actual results were about $6 million worse than budget. You can see roughly $400,000 of that is due to premium contributions being slightly lower than budget for the non-payroll groups. Looks like it's just a timing thing from month to month. Other revenues make up the lion's share at $9.6 million worse than budget, which is predominantly driven by the fact that the 2024 EGWIP year-end reconciliation payment was actually received back in November of this year, when it was built into the budget expected to be received in January, and that makes up about $9 million of the $9.6 million. Claims continue to run better than budget, predominantly on the commercial pharmacy side, mainly due to the fact that actual GLP-1 expenditures have come in lower than were originally budgeted, and expenses came in about $500,000 out of budget due to a CVS performance credit on the Silver Scripts program, making up the total of the $6 million worse than budget. You can see at the bottom half of the chart, this is a full year reforecast reflecting the 7 months actual and 5 months future expectations for the full fiscal year 26, with the current expectation that the full year will end about $15 million ahead of budget. So let me pause there and see if there are any questions specific to any of the details on the January financials.
Just
Commissioner Navarro.
so the $3.5 million reduction in claims, or at least better than budgeted, and it says better than budget due to lower GLP-1 utilization. How do you quantify that as far as people go? And does that mean that fewer people are taking GLP-1 drugs?
Fewer people are taking GLP-1s than were expected in the budget. So a lot of that happened. Recall that CVS changed the formulary on July 1st to remove Zepbound in favor of solely covering Wegovy. And at the time, it was expected that utilization would continue to increase regularly over the prior period. What we saw in July was a big dip, meaning that a significant portion of those people who were taking Zepbound did not switch in favor of Wegovy. And while we saw continued month-over-month increases, they were roughly at the rate that we were expecting in terms of the budget, but never saw a rebound effect from the prior Zepbound users. So it's not that fewer people are taking them, it's fewer people are now taking them compared to what we expected in budget.
Yeah. So you may not be able to tell me this, but so do you think these people just elected not to take a GLP-1 drug any longer? And these drugs, although they're similar, are not the same. So people have side effects from one drug to another. Do you think that's a factor as well?
There's no way for us to know whether or not they continued to take Zepbound and pay for it out of their pockets through, a direct-to-consumer channel or not. I'm guessing that a number of them did discontinue taking a drug altogether, and probably some did continue to take Zepbound and pay for it out of their pocket. But we don't have the data to truly address that.
Okay. So the 3.5.
No, that's for the entire year.
Okay. All right. Never mind. Thank you, Brian.
Sure. Lieutenant Governor Gay.
Thank you. I believe that was the insurance commissioner speaking, and I think in addition to asking the right question about utilization and what might be behind it, I mean, it doesn't take a genius to know that you're not going to get in to see a doctor or even get a doctor to, between June 25th and July 1st to give you a whole different prescription. So I think we need to look at this as a very real indication of how our decisions can affect the ability to access medications. And in addition, I think it's important for us to start to understand that the demand for these weight loss medications is not decreasing, and the rate of demand is increasing, and that the options for individuals to access these drugs or generic identicals is also increasing. And so I would suggest that it would be helpful in order for us to make policy around GLP-1s moving forward, that the SBO endeavor to ask our employees and their families if they are accessing any of these types of drugs, either on the plan or outside the plan. And that will help us, I think, better make decisions to assist them moving forward.
Anything else, Brian, you have?
Not if there aren't any other questions.
Move on to public comment.
I will ask if you plan on making a public comment, to please raise your hand so I can unmute your mic when you are called upon.
Secretary Gordon, do you have a comment before we start public comment?
Yes, I do. Going forward, I would like for us to consider, so I have to put it in the form of a motion.
We'll do that after this. Hold on. We'll do that after this.
Oh,
We'll
after
do that on other business. So we're
you're
gonna do
under
public comment.
13. You're under 13.
Yes, we're gonna go to 14. You're
Oh,
under
I
14.
apologize. I'm sorry.
No,
I
no problem.
apologize. Thank you.
I do have two individuals that did sign up for public comment. I will call on the first one, Paul Rabinovich. I don't see a hand up.
If you're calling in from your phone, you can hit *6 to raise your hand.
With seeing none, I will go on to the next request. Christina Bryan.
Yes, good afternoon. My name is Christina Bryan with the Delaware Healthcare Association. DHA is opposed to Senate Bill 1 as currently written and cautions the SCBC to consider that this approach poses a serious threat to healthcare access, quality, and Delaware's healthcare workforce. SB 1 runs counter to the recommendations made by the Primary Care Reform Collaborative and the robust stakeholder process to enact at least a 2-year extension of the existing primary care law, while Delaware explores the federal AHEAD model and other value-based care initiatives. Value-based care is how we can work together to address affordability while not sacrificing quality and access in our uniquely growing and aging state. Arbitrary reimbursement caps like the 250% of Medicare reference-based pricing provision included in SB 1 would take us backwards. Medicare pays significantly below the cost of care, so the 250% of Medicare reimbursement cap included in SB 1 would result in a healthcare services cut at a time when we are already facing federal Medicaid cuts. Hospital budgets are spent on employing their healthcare workforce. SB 1 revives a dangerous 250% of Medicare rate cap that was rejected in House Bill 350, conservatively resulting in a $165 million cut to Delaware hospitals across the state and potentially impacting as many as 1,500 healthcare jobs. Delaware is now the 5th oldest and 6th fastest growing state in the nation. We need more healthcare workers, not less. Delaware hospitals provide the majority of the primary care in Delaware, employing over 500 primary care providers in the first state. They invest significant resources in and in fact lose more than $70 million annually supporting primary care in Delaware. We're also investing in bringing more primary care providers to Delaware through Delaware Hospital's graduate medical education programs, which come with significant financial investment from our hospitals. These programs have brought nearly 200 new primary care physicians to practice in Delaware in the last 5 years. We need to grow these programs, not limit hospitals' ability to afford to keep them or keep doctors from wanting to come to Delaware to practice. Finally, the General Assembly just passed SB 213 in January, and the Hospital Cost Review Board is now up and running. That's a major healthcare policy now being implemented with unprecedented transparency into hospital costs and holding hospitals, not pharmaceutical companies or health insurers or any other healthcare sector, accountable to the state's healthcare spending benchmark. SB 1 renders that process and progress moot by establishing a price control that will not make concessions for the growing needs of our state, including our doctors and nurses and our growing primary care needs. We hope to work together with all of you and Delaware legislators on a solution that addresses affordability without cutting quality access on our healthcare workforce. Thank you.
Thank you. Go on to the next hand raised, Jessica Karen Green.
Hi, I'm with the Department of Natural Resources and Environmental Control in the Director's Office. I do use the GLP-1 medications. I started last year on Zepbound. And, you know, we had to switch to the Wegovy, of course. With it going up to $200, my doctor charges me $85 to just call the medication in. So it's not just $200 for me, it's $285 if, you know, that health savings card goes away. I mean, and still it's $185 now instead of the $32. I don't know about you. I make $40,000 a year. and I have 2 kids. $185, that's a lot for me, or 285. I mean, these medications, just because it's used for weight loss, I think, you know, they're kind of, oh, well, you know, you can use diet, you can use exercise, you can use this or that. I tried everything. I tried diet, exercise. I exercise every day. This helps people as a whole, not just, oh, I lost weight, I'm skinny now. Like it, you know, it's something that affects your mental health all the way around. So to raise those copays to $200, it's really disappointing, you know, to me, and I'm sure to many other people who use these medications. Thank you.
Thank you. Is there anyone else that would like to make public comment? Please raise your hand at this time. Seeing that there is none, I do want to state that there were 96 written comments that were provided to the SCBC committee prior to the meeting for this meeting. Okay. Seeing no.
All right, we'll move on to other business regarding public comments. So, I spent a number of weeks in Joint Finance Committee, and Joint Finance Committee does take public comment at the end of each one of their hearings, when an agency comes in, and the time allotted for public comment is 2 minutes, which is the standard. But I see the SCBC has been following a 3-minute rule. So I would just like to put it forth out there. Do we want to continue with a 3-minute rule? We are now in this room for over 3.5 hours. We didn't have a lot of public comment today, but there could be in the future. Just want to see what people's thoughts are with regards to public comment. Go over.
Mr. Chairman, I have actually testified before the Joint Finance Committee several times, and 2 minutes isn't enough time to really capture, I think, what people would like to convey. So I'm very comfortable with the 3-minute current provision.
Yeah, the other thing we could do is if we had, you know, a huge crowd show up or a huge list, you can also on an ad hoc basis just say, because of the number of people, and I've done that with Newcastle County Planning Board meetings, you know, 100 people show up and want to talk, you know, we might have to cut it to 2 minutes or, you know, to 1 minute. I mean, that gives you 1 minute to make your case as a member of the public.
Yeah, I just would want to change the rules of the game based on the number of people. And I get people do that, but I would just, people prepare for theirs. And to Bill's point, some people have best intentions of getting their thoughts through in 2 minutes, but a lot of times they're not able to do it. So I just wanted to bring it before the committee. It's not a hill I'm going to die on, but I just wanted to throw it out there for the committee, whether we wanted to make that change. I would like to hear from others as to what others think about it. Lon?
I think public comments are the length of time you give them. So if you give them 2 minutes, I think they stick with the points for 2 minutes. We're fortunate that most of our public comment has been in writing. But I would prefer that we move to the 2 minutes, because that's consistent with the expectations too of the public.
Treasurer Davis?
Yeah, I would agree. I mean, just for the volume of topics that we're trying to cover, I just think if we can keep it to 2 minutes, that would be great. And then, you know, individuals continue to have the option to put their comments in writing.
Any other comments? I will table any further discussion on this until a later date, but if you feel strongly to make comments publicly, feel free to reach out to myself, Director Hartos, about this particular issue. Seeing that we've reached the end of this agenda, I'll entertain a motion to adjourn.
So moved.
All those in favor say aye.
Hi.
Yeah.
Those opposed, there are none. Meeting adjourned.
And hungry.
Thanks, everyone. Take care.
Aye.